we have to continue for some more days. Which preparation? There are two types of preparations we can give. Daily injections also we can be giving, or depot preparation also we can give. Leuprolide acetate 3.75 milligrams single dose. If you give, the patient will be getting like usually after 10 days periods. Just do the scan and check for whether it is down regulated. Then we can any day of the day, like suppose it will be very useful if you are doing batch IVF. So any day after 1 week also you can start the stimulation. After 10 days, 15 days also we can start. That is one advantage if you give the depot preparation. Then after that we will be starting the gonadotropin. That we'll see how much gonadotropin I will tell you later. Then when follicle reaches around 18 millimeters, then we will trigger with the HCG. Next is shock protocol. I told you already, if you go for the long protocol, it can over-suppress the patient. The number of follicles may not be sufficiently developed when, particularly the patient with decreased ovarian reserve. That's why they develop other protocols, of which one is the shock protocol. Here what we will be doing, we will start the agonist protocol on day 2. Then the gonadotropins from day 3 onwards. This agonist will be continued up to the follicle reaches 18 millimeters. Then we will decide to give the trigger. Until that we will be continuing. This we will call it as shock protocol. Here in some patient, even this can over-suppress the patients. He may not get many follicles. That's why they want to go for the other protocols, ultra-short protocols. Here they will give only 3 days, day 2, day 3, day 4, and day 3 onwards they will be starting the stimulation. And also they want to utilize, I told you, when you are give the agonist, there will flare effect will be there. So that will be in the patient itself, whatever FSS LH is there, that also will be released. That benefit also we can utilize in this. Suppose if there is LH is raised, you have to monitor the LH. If needed, then we can give the antagonist also to prevent premature LH. When the follicle reaches around 18 millimeters, then you will go for the trigger. In microflare, so here until now we are not sure what is the exact dose of the agonist. That's why they tried here leuprolide acetate 40 micrograms twice a day from day 2 onwards until the trigger, HCG trigger, and we will start the gonadotropins from day 3 onwards. This also will help in the low reserve patients. And same way we will give the trigger when the follicle reaches around 18 millimeters. Then we will go for the antagonist protocol. Here, see, it takes 10 to 14 days for agonist protocol to complete it down regulation. That means long days, number of days. Then only we can start the stimulation. Whereas in antagonist protocol, it takes only 4 to 6 hours. Just it goes and blocks all the receptors, GnRH receptors, then it will be suppressed completely. That is one advantage. So after that, there is no flare effect also in this. There will be, that is the advantage of this one. Here what we will be doing, directly we will start the stimulation from day 2 onwards. We will be starting the gonadotropins. There are two types of protocols are there. One is fixed, another one flexible. I will tell you later. The antagonist, I told you, fixed protocol, flexible protocol. Fixed protocol means after starting the gonadotropins, 6th day we won't bother about the size of the follicle. We will start 0.25 milligrams cetrorelix or ganirelix. Whereas in flexible protocol, we will see the follicle size. Whenever it reaches around 14 millimeters, then only we will start the cetrorelix, otherwise we won't start. It may be on 7th day, 8th day or something like that. So we will be saving the drug here. At the same time, we are not suppressing the estradiol in that particular patient. This is what I told you. We will be starting on the day 2 of the gonadotropins. Once the follicle is on 6th day, you can start the antagonist. So that is called fixed protocol. Otherwise, we will monitor the follicle. If it reaches 14 millimeters, then only we will start the antagonist, either cetrorelix or ganrelix. Then we will wait until the follicle reaches around 18 millimeters. Then only we will give the HCG trigger. So when it goes to ovarian stimulation for IVF, so we have to see there are so many factors we have to take before starting. One of the age of the patient is very important, and any other risk factors like whether she had any previous surgeries on the ovaries, whether she is having associated disorders like endometriosis, PCOS, all these things we have to see. Next is, suppose if she gives history, whether she had any previous IVF protocol, whether she responded poorly there. And also, like, we will do the ovarian reserve test day 2 to day 4, that is better. Here FSH, LH, EU2 or AMH. Next is antral follicle count. So these are the things important. If the AF count is less than 7 or AMH is less than 1, we will call it as these patients are low responders. Then we have to take decision how to stimulate these patients. So depending on that, that's why any patient comes to us, we have to see under which group this patient will come. Whether she is a low responder, normal responder or high responder, whom we will call it as low responder. If you do the FSH, if it is more than 10, if the estradiol level is more than 90 picograms, or AF count is, I told you, less than 7 AF count, or suppose if she had previously IVF some other place, if she comes to us with the report, the highest peak estradiol level is less than 900 picograms during that stimulation, or they retrieved less than 5 oocytes, all these tell us that this patient is a low responder. So we have to take precautions. Accordingly, we have to plan for the stimulation. When you will call it as high responder, one simple thing is all PCOS patients are high responders. And suppose if she had previous IVF, there if the E2 levels, estradiol levels is more than 3000 picograms per ml, this is also indicates that she is a hyperresponder. Or if the more than 2 follicles or small follicles on the day of trigger, if it is there, all small follicles, this is also, this patient is going to respond, high respond. And if you estimate the AMH, I told you it is more than 3.6 or 4, above which we will call it this patient is going to hyper respond. And also, like, if you take the AF count, so more than 12 to 14 in each ovary, that patient also is going to respond, hyper respond. So then we have to decide how to start the dose. This is important. There is no fixed like that. Somebody developed this is the protocol, like approximately they decided. High responder, you can go start from 75 to 150 IU. Intermediate responder 225 to 300 IU per day. Low responder 375 to 450. Usually for 5 days we will give this one. 6th day we will do the scan. Depending upon the response, number of follicles, growth of the follicle, we will decide. If the follicles are more or the follicles are growing fast, we will reduce the dose. Suppose the follicles are not appropriately grown, number is there, then we will increase the dose. That way we will be modifying the dose. Depending upon the age also we can decide. This is the normally, so this is the dose. If the age is less than 30 years, the starting dose is 225. If the age is in between 30 to 35, add 75, that is 300 IU. If it is more than 35 years, 375, that is the starting dose. In addition, we have to see if these patients are low responder or hyper responder. Suppose if it is low responder, add 75 extra for this patient. Suppose if she is a hyper responder, reduce 75 from this one. So you will get this way we can start for 5 days, then we can decide after doing the thing. This is all just like approximately we will be doing. Nowadays, there are individual stimulation protocols. They have developed some nomograms. Yates developed, depending upon the AMH levels, he has decided how much to give. So whichever patient is having the AMH is more than 4, he decided it is called as hyperresponder. The dose is 150 IU of HMG and antagonist protocol is the best for the hyperresponders. If it is AMH 2.1 to 4, this is normal responders. Depending upon whether you are giving HMG or recombinant FSH, HMG means 225 IU, and recombinant FSH, the potency will be better than, consistency will be better than the recombinant. That's why we will be giving slightly lesser dose, 200 IU is enough. Both protocols you can use here, same thing. Either you can go for the agonist protocol or antagonist protocol. If the AMH is less than 2, that is up to 0.3, this is poor responders. Here we have to go for the higher dose, that is 300 IU of HMG. Always for poor responders, if the patient is more than 35 years, they need some amount of LH for the stimulation. That's why go for the HMG and stop starting the recombinant FSH alone. Here antagonist protocol is better. Some people will be trying the agonist protocol also. If the AMH is less than 0.8, so this patient not advisable. If the very patient is very particular, then we can tell them, I will try trial stimulation, give for 5 days and see how many follicles are developing. Then you can take decision whether to continue or not. Then if she wants to continue, some people are very particular about their own oocyte, then you can continue. Otherwise, stop the thing. Advise them for the donor oocyte program. Lamarca, that is only has that AIDS has taken only AMH. Lamarca, if you increase more number of factors, so then the minor difference of that dose also we can adjust. So he has developed two protocols depending upon the age and AMH. This is the one nomogram. Another one he has taken the AMH, age and FSH also, so that even like minimal decimals also like that, you can instead of 150, 153, 154 also they can get. That makes, there is a threshold dose is there, above which suddenly it will hyper respond, below which it won't respond. That is the problem for us. That way we can use. Next is minimal stimulation protocol. Here, so there are various varieties are there. We can use the oral oval agents. Clomiphene citrate is not the 50 milligrams of clomiphene citrate and day 3. This continue until the follicle reaches around 18 millimeters. The advantage of that one, it prevents the LH surges also, that is one advantage. Disadvantage, it is having anti-estrogen effect, so we cannot go for immediate transfer. Suppose the response is not that much thing, then we can start the low dose from 8th day like that, or alternate day after stopping the after 8th day onwards like that we can give. For either you can choose HCG or agonist trigger for trigger. Next is letrozole also we can use. Here letrozole always better to give the previous cycle oral contraceptive pills and give a gap of 4 to 5 days for the washout period. Then start the letrozole with 5 milligrams per day and here for 5 days. Then if needed we can start the HMG 150 IU from last day of the letrozole. Then here definitely we have to prevent the LH surge by cetrolix. Then you can decide whether it is fixed or always better to go for the flexible protocol. Next is if you decide to go for only gonadotropins, here we can give the gonadotropin dose not more than 225 U. Less than 150 is better. Always same way we can start from day 2, day 3 like that and give same way. Here also they will be requiring the antagonist to prevent LH surge, and same way we can trigger ovulation by LH. Next, what are the drawbacks of minimal stimulation? Risk of premature LH surge is high in these patients. Need for constant monitoring, otherwise this problem can occur. And always, because the low dose we are giving, each patient will respond differently. The number of oocytes what we will be getting will be less, and many patients they will get cancelled because not sufficient oocyte follicles will be there. So as the number of oocytes are less and the fertilization also will be less, the embryo transfer rate also will be less. Many patients will be cancelled, so the pregnancy rate also will be less in this patient. Sometimes we may have to go for the multiple control ovarian stimulation protocols, particularly in the low responder and decreased ovarian patient. The number of oocytes what we got is 2 or 3 like that. That may not be sufficient. So many times we have to stimulate, many cycles we have to go, pull these oocytes and embryos, then you can go for the transfer. For this, one is double stimulation regimen SEER stimulation protocol, 2 successive ovarian stimulations with 2 oocyte retrievals. At the end of both ovarian stimulation, if you are able to do within 1 month, we will call it as double stimulation. The first ovarian stimulation usually starts in the follicular phase, day 2 or day 3. Then after retrieval, after 1 or 2 days, we can give the gap and start the second protocol. This is the way we will be starting day 2, day 3 first thing. So here trigger always with agonist trigger only. After that 2 days, 3 days like that. Again second we can start stimulation with recombinant FSH only better here. Then you can go for the antagonist. This is also particularly useful in cancer patients if you are planning for the fertility preservation. Conclusion: newly developed protocols are efficient in inducing COS and obtaining appropriate number of oocytes and embryos. Determination of the COS protocol and gonadotropin dose requires an individualized assessment. Just by seeing this one or listening to that one, reading books, it's not possible. You will develop your own expertise. Use that one so that we can prevent the main complications, OHS, that we can prevent by doing individualizing these things. Thank you.
Thank you, sir, for your detailed and excellent presentation. So it's my honor to share the same platform with my mentor, guide and teacher when I was doing MCH. And all the PGs should take him as an inspiration for his dedication and hard work. Thank you, sir.
Thank you, sir. Very nice presentation.
So November 25th, 26th, 27th, we'll have 4 halls for the clinicians, 2 halls for the embryologist, and also we have put 4 pre-paper presentations also. Please tell your PGs and whoever interested, you can block your dates and attend. You will enjoy. Thank you.
Thank you, sir.
Sir, one moment. We will like to give you the memento on the certificate. I would request Dr. Bharati Madam and Sai sir to give. Madam. Next session is Zoom. Next topic is robotic surgeries in gynecology by Dr. Meenakshi Sundaram Madam. Because of unavoidable circumstances, Madam is not able to attend virtually. So we are planning Zoom session.
So our next speaker is Dr. Sudarshan S. And sir is a consultant at fetal medicine at Mediscan Center. And sir done his fellowship in fetal medicine at Mediscan systems. And his clinical focus is on first trimester screening and high risk multiple pregnancies, invasive procedures. Thank you, sir. You can start your presentation.
Okay. A very good morning to the audience who have come here, and a big thanks to the organizing team for having invited me to this talk. So this session over the next 30 minutes is going to be on fetal reduction. And when we think of fetal reduction, the first thing that comes to us is something like what we see on the screen, where we have multiple fetuses inside the uterine cavity after either assisted conception or after stimulation. But what is fetal reduction all about, and is there a process to it, and how can we optimize the outcome, and is it a straightforward process where we see multiple pregnancy or a higher order pregnancy where we just go and stop the blood flow of one or more babies, or is it something more than that? I hope to give clarity to that in that regard over the next 30 minutes. So when you look at multifetal pregnancy reduction, there are two kinds. One is your selective termination, where you have a multiple pregnancy where one baby is anomalous, as I've shown in there. This is one of a twin pregnancy which is having a acrania. Or you have a higher order multiple pregnancy like this, where you have triplets or more, where we try to optimize the pregnancy outcomes by trying to reduce the overall number of fetuses inside the uterine cavity. So when you look at the background following IVF conceptions or ovulation inductions and stimulation agents like HMG, the incidence of higher order multiple pregnancy is significantly higher, and the primary worry that we have is that over half of the twin pregnancies and the higher order multiple fetal pregnancies deliver before 37 weeks. But our concern is not 37 weeks, our concern is about a large subset of these pregnancies who end up delivering much earlier because of the over distended uterine cavity. And once you have preterm birth, it is the single largest cause of lifelong neurodevelopmental morbidity. And if you look at the numbers that are on the screen, they are very stark. If you look at neurodevelopmental disability due to severe prematurity, the incidence dramatically increases from singleton to higher order pregnancies like triplets, quadruplets and quintuplets, from 1 in 400 to close to 1 in 10. And if you look at some data from abroad, this is data from around 4 or 5 years ago, when you look at triplet pregnancies, quadruplet and quintuplet pregnancies, close to 98% of them are delivered preterm, 37. Our worry is the early preterm before 34 weeks. And if you see, around 2% of singleton pregnancies deliver before 34 weeks, while when you have triplets and higher order, it increases to over 60%. And again, the incidence of very low birth weight preterms increases from around 1 to 2% to close to 30%. Our single goal in trying to do an intervention in these group of pregnancies is to eliminate the second group of early preterms and very low birth weight infants in order to improve the overall pregnancy outcomes. The second part is that the incidence of major maternal complications also dramatically increases as you progress from singleton to triplets and quadruplet pregnancies. And if you can see that the incidence of preeclampsia, gestational diabetes and preterm labor exponentially increases from singleton and higher order pregnancies. And the third part, when you have a higher order pregnancy, is that the patient and the family are really put to a significant amount of not only physical and emotional stress, but that's a significant financial burden also. And considering all these factors, what we try to do when we handle a higher order multifetal pregnancy is that we try to put it across to the family, and we try to explain to the family what are the risks versus benefits when you want to embark upon an intervention. Because all these interventions are also not 100% safe interventions, because each of these procedures carry with it a slightly higher risk of early or total pregnancy loss also, and that depends upon multivarious factors. So let's divide them into triplets, quadruplets, and some complicated triplets, and let's look at what the evidence is. And understanding this evidence is very, very essential, because when we talk to patients, when we counsel families, we counsel them with these clear numbers, because that's what will enable us to have a very objective way of approaching these problems. So when you look at outcomes of triplets, this is a large systematic review, and which looked at the pregnancy loss rates alone for expectant care versus multifetal pregnancy reduction, and this is somewhat similar of around 7 to 8%. And when you look at the preterm birth rate before 32 to 33 weeks, and that is what changes significantly. When you do a reduction, it's around 10 to 12%, and when you have an expectant management, it's 3 times more. So again, we look at it in the form of graphs. So when you have a triplet pregnancy, which is trichorionic triplet, and when you compare expectant management versus doing an intervention of reduction into twins, the miscarriage rate overall remains the same, around 7 to 8%, while the preterm birth rate reduces significantly from, as I said, various numbers, 35 to 50% to less than around 15 to 17%. So the elective reduction to twins mainly reduces the overall risk of preterm births without increasing the background risk of miscarriage. So when we counsel a family about risks of a fetal reduction, the key numbers that are used to put things across to them is that fetal reduction, yes, carries a risk of miscarriage to the pregnancy, but it is not over and above the background risk of miscarriage when you have an expectant management of the triplets. The second group of triplet pregnancy that we are faced with is a dichorionic triplet. It is not as rare as we think, it is pretty common. And when we have a dichorionic triplets, the dilemma that we have in front of us are 3. 1, do we reduce the monochorionic diamniotic pair and continue the singleton pregnancy? Or do we reduce the singleton pregnancy and continue the monochorionic pair? Or can we reduce one of the monochorionic pair alone? So when you look at dichorionic triplets, the complications are 2. Other than the very preterm birth that are there, you have a monochorionic twin inside, and monochorionic twins per se have around 15% risk of complications like twin transfusion syndrome and selective growth restriction. And handling them in the setting of a triplet gestation is almost very, very difficult. Again, when we look at data of reduction, so these blue bars are the dichorionic triplets managed expectantly. The red bars are the dichorionic triplets managed by reduction of the twins, and the last bar is where we reduce the monochorionic pair and continuous singleton pregnancy. And I don't need to read out the numbers, the graphs per se are striking on the face. What happens from a triplets to continuation of a singleton, that is by reducing the monochorionic pair, the preterm birth rate reduces from close to 80% to 8%. The very preterm birth rate reduces from 23% to less than 5%, and the low birth weight and very low birth weight rate also reduces very, very significantly. So when you have a DCTA triplets, reduction of the monochorionic diamniotic pair enables us to reduce the overall complications of the pregnancy significantly more, and these are the numbers with which we explain to family. This is a dichorionic triamniotic triplets. You have a MCDA pair here, and you have a singleton fetus here, and this is the reduction of one of the MCDA pair, and the same needle goes on and reduces the other MCDA pair. So it is ideally preferable to reduce both the fetuses in the monochorionic pair at the same sitting. If we reduce one fetus alone, in around 24 to 48 hours, the co-twin of the MCDA pair also undergoes demise, or if it does not undergo so, we will have to repeat the procedure for the other twin also. But sometimes when we have a dichorionic triamniotic triplet, we are faced with this problem. So this is a singleton baby, this is the MCDA pair. A detailed anatomical assessment before reduction showed that the singleton baby had a complex cardiac anomaly. CRL was 55 mm. This baby had a single chamber heart, and hence we clearly know now that that the singleton fetus is having a major lethal abnormality. So if the singleton fetus has a major structural malformation, then we can do a reduction of the singleton. What this puts across as a message is that a very detailed anatomical assessment prior to reduction is extremely essential. So with these concepts, DCTA triplets, which is the best choice, reduction of the MCDA pair is the optimal choice. If the singleton has got a major abnormality, then we reduce the singleton pregnancy and continue the monochorionic pair. And when we continue the monochorionic pair, the residual risks of TTTS and SFGR remain, and hence the pregnancies need to be monitored 2 weekly from 16 weeks. The third part is that is it possible to reduce one of the MCDA pair? We have tried it for a couple of cases and there is some evidence on that, but the overwhelming evidence, that is when we want to reduce one of the MCDA pair, we have to do it by a procedure called an intrafetal laser, but the risk of co-twin of the MCDA pair undergoing demise is close to around 40 to 50%, and hence the uncertain benefits with a higher risk, it's a procedure best avoided. So the next group is when you have a DCDA twin. We saw a triplet and we saw a higher order pregnancies. What about twins? When we have a twin pregnancy, we are faced with the process of needing a selective reduction in the setting of these indications. If one fetus has got a major lethal abnormality, or an abnormality which has got a significant morbidity postnatally, or the patient is one who's had multiple prior mid-trimester losses or recurrent miscarriages, or she's got a uterine anomaly or a unicornuate uterus, or there is a maternal medical disorder with a very poorly controlled diabetes or uncontrolled hypertension, or an autoimmune disease where a patient is taking multiple drugs. And in all these scenarios, we feel that either due to a fetal indication or due to a maternal indication, the pregnancy outcomes would be much more optimal at the singleton than we embark upon a selective reduction in a DCDA twin. Elective reduction for a well-growing DCDA twin for a maternal indication is very, very questionable. The ethical choices and the overall risks are more, and hence is best avoided. So overall, when we have a DCDA twin, we will have to consider the risk versus benefit ratio in a procedure, because the outcomes of spontaneous DCDA twins is very well for the patient and the fetus, and hence if we have got to do a reduction, it's got to be for a very clear maternal or fetal indication. And in this regard, the risk rate is much lesser because the starting number of fetuses is lesser. The procedure related risk loss is very low, it's around 2 to 5% only, and the resulting singleton pregnancy has got a significant reduction in the late preterm birth also, and overall the composite adverse outcomes are very less. So we have again some things which are beyond the routine. So we saw triplets and twins with an abnormality. Here we have a group of dichorionic twins. I put across 3 cases to see what can faces. This is a dichorionic diamniotic pregnancy, but it's actually a triplet. You have a singleton fetus here, and you can see a conjoined twin here. Again, you have a dichorionic twin pregnancy, but it's actually a bicornuate uterus with the twin fetuses in one horn of the bicornuate uterus. And this was again a dichorionic diamniotic twin gestation in a woman who had 3 prior mid-trimester losses. The circlage had been done very early, and the cervical length was around 2.6 centimeters. In all these scenarios, what you can see is that a very clear assessment has been done at the early part of gestation. So we are clear in all these cases that the monochorionic, the conjoined pair has to be reduced. Here a reduction is because the outcomes of the pregnancy are improved because it's part of one horn of a uterus, and this is a pregnancy who had multiple prior losses. Right. So when you look at the third group, again I'm putting up a lot of evidence, because what we see is that when we counsel these couples and families for fetal reduction, patients ask a significant number of queries. And one of the queries a lot of patients come again and ask is when they come with a triplet gestation, some of them want to reduce it to a singleton pregnancy. They don't want to reduce it to a twins. And if you look at the outcomes, of course the overall outcomes of composite neonatal morbidity that is the NICU admissions, the RDS, and the severe preterm birth, reduces when you have a singleton versus a twins. But when you look at the other aspect is that the first trimester scan enables us to overall assess for only around 60% of the major malformations, and in the event of we reducing it to a singleton pregnancy, the patient has to understand that a group of structural malformations may present in the second trimester, and that would be an uncertainty they would have to face. So the final evidence is that the option of reduction to a singleton from a triplet gestation should be considered only when the risks of prematurity seem exceptionally high, because the benefits of multifetal reduction to singleton versus twins does not change much. So with this background information on what data that we use to counsel the patients, let's go through the stepwise process that is done. Step 1 is the evaluation process, and that is best done in the early pregnancy by around 8 to 9 weeks, where we assess the chorionicity. This is a trichorionic triplets, this is a dichorionic triplets, and this is actually a monochorionic triplet. And at 8 to 9 weeks we assess the number, the viability and chorionicity, and we do the first session of counseling where we explain to them the whole process and put it across to them. The patients have got a significant amount of anxiety because vast majority of them have come at this juncture after a long period of fertility issues. And we explain to them that the intervention is done at around 11 to 12 weeks after an anatomical and viability assessment, because a group of pregnancies undergo spontaneous reduction of one of the fetuses by the time the pregnancy reaches 11 weeks, and then we prepare the patient. So these are the different chorionicities that we see. For example, this was a pregnancy which came at 8 weeks, and when they came at 11 to 12 weeks, all three fetuses were actually non-viable. And here this was a dichorionic triplet, where when we saw them back at 12 weeks, the MCDA pair had undergone spontaneous reduction, and hence we would not have needed any pregnancy procedure at all. So the second step in the evaluation is 11 to 12 week assessment, and ideally we do these interventions between a CRL of around 50 to 55 mm. We assess the chorionicity, we look at major structural malformations, we look at the placenta if there are any areas of hemorrhages or clots, and we look at the adnexa, and then we triage the pregnancy. And a simple triage process is that we triage the fetuses based on CRL, the nuchal measurement and the anomalies. And the fetuses with the smaller CRL, the larger nuchal, or one fetus with the anomaly is what is chosen for a selective reduction. And in the absence of any of these features, the embryo that is most technically accessible and farthest away from the cervix is selected for reduction. So this was a trichorionic triplet pregnancy. This was a nuchal for fetus A, nuchal for fetus B, and if you look at this, fetus C has got a nuchal of 5 mm with an absent nasal bone, and hence an assessment at this juncture enabled us to choose the right fetus for a fetal reduction. When you look at structural assessment, we do see a significant number of structural malformations in one of triplets or higher order pregnancies. This is a triplet with one fetus having a large cephalocele. This is a triplet with one fetus having an acrania. Again, subtle malformations, a small spina bifida, very easy to miss, but a good assessment prior to reduction can pick this up. Again, this was a triplet, this was a twin gestation who came for a routine pregnancy scan. Fetus A is completely normal, fetus B you can see has got a severe micronathia, and a selective reduction of this fetus was done at this point of time. So again, a twin pregnancy, twin B is completely normal, normal nuchal, normal nasal bone, while twin A, if you look at video, has got a cystic hygroma, and the baby has got a complex cardiac anomaly, a left heart hypoplasia, and hence we were able to identify this and consider this for a selective fetal reduction at this point of time. So the key message that I want to pass on by these cases is that a lot of time must be spent on a thorough structural assessment of these pregnancies, because we don't want a scenario where we reduce one of the fetuses and an identifiable abnormality is seen in one of the remaining fetuses at the time of the 20-week scan. And this may take time and it may take effort, but at the end of the day, this time and effort is worth the time. So the third process in this protocol is that it is ideal that these pregnancies have a urine culture and a vaginal swab culture prior to coming for reduction to rule out any subclinical infection, and they can be treated. And antibiotic dosage are not investigated by any trials, but we use a single dose of broad spectrum antibiotic just before the procedure. We have a checklist for the intervention. It's always best to have this checklist so that we don't miss anything prior to counseling the family. And having consents and counseling forms are essential. This is a very standard consent form that is done for the procedure, where we explain to the patient what is being done and what have been assessed and what are the risks of the procedure, and the fact that the baby needs to be followed up to look for evolving concerns later on. And then per records of PCP and DT Act, we've got to get the form F signed by the patient and the form D also signed by the patient. And all these forms are essential. We have a checklist form, we have a consent form, we have the form F and the form D, and these have to be mandated by this, and hence you need to have a dedicated personnel to go through this process. This is a standard tray for a selective fetal reduction. We have the disinfection set and the complete covering draping set. And for the procedure, we have a 22 gauge 15 centimeter long needle, and 1 ml syringes. We use either lignocaine or potassium chloride injection for the same. So as I said, we screen the fetuses prior to the procedure to see how the fetuses are. You can see there's a very large area of hemorrhage seen between the sacs, and we reconfirm the process and consent from the patient. And this is the steps. So in the first step, the needle is entered inside the cavity. You can see the needle going right inside the cavity, and it is brought closer to the fetal thorax, and the fetus is kept in a transverse plane. A zoom of the thorax is done, and once that is done, the needle is got inside the fetal heart, and color Doppler is used to show the drug elution inside the thoracic cavity, and we check the fetal heart rate at the end of the procedure. This was a quadruplet actually, so the other fetus is also reduced in the same sitting in the same manner, and we'll be able to document the needle inside the cavity, in the heart, and the absence of the cardiac activity. In skilled hands, the procedure takes hardly a couple of minutes. So once the process is done, we check the heart rate of all the babies. Sometimes the fetal heart goes into spasm and it may restart, and hence 30 seconds check of the color flow must be done to be a foolproof. We've had patients who have had a fetal reduction and have come to us elsewhere and referred to us at 16 weeks, where they have seen again a triplet gestation. Hence very essential to go through this process. And as I said, we usually reduce the fetus that is closest to the fundus if all is concordant. This is fetus C that is closest to the fundus, and that is undergoing reduction. We reduce, if we have to reduce a fetus near the bladder. This was fetus A having an anomaly, so we got to fill up the bladder partially. This would push the uterus away, and hence the access for the reduction would be much easier to go through the process. When we see a higher order multiple pregnancy like a quadruplet pregnancy, we choose the simplest and the easiest route to go. Here we have A, B, C and D, 4 fetuses sacs that are there, and to reduce the number of needle pricks, what we choose here is that we reduce these 2 sacs because they are inline, so this reduces the number of needle pricks inside the cavity. So this is fetus C that has been reduced, and the same needle that has been redirected right across, and the other fetus has been reduced. So optimizing the technique to reduce the number of needle pricks again improves the overall procedure outcomes. Sometimes you have a patient like this. This was a patient who had multiple surgeries, very high BMI, very poor visibility. You can hardly see where the pregnancies are. So we got to use color Doppler as a goal to direct the needle entry. This is a needle entry. We have to see the entire needle path going in only using color Doppler. This requires a lot of experience. So sometimes we have a very higher order multiple gestation. This was an octuplet and a septuplet pregnancy. We shouldn't be seeing all this, but when we see this, what do? We can't reduce all of them at 12 weeks. So we've got to do it in 2 sessions, one at around 9 weeks where we reduce it to a triplet or a quadruplet gestation, and then come back at 11 weeks to do an anatomical assessment, because we don't want more than 3 needle pricks at a 9-week baby. Exponentially increases the risk of miscarriage. So post procedure, we give these instructions to the family that there can be some amount of leaking or spotting or bleeding post procedure. It's very common, it's not concerning at all. We give a note with these red flag signs. If the patient has got fever or heavy bleeding with clots, then this is a red flag sign because these are signs of infection and they need to contact the clinician immediately. Normal diet, we give around 4-5 days of oral antibiotics from day 1 of the procedure, and we get them back at 16 weeks for a cervical check. Post procedure, these twins need to be followed up closely, and the reduced twins, as per evidence, do not follow the true growth curves of the non-reduced twins. They retain the suboptimal growth curves as triplets, and we need to have this in mind because some of them have growth restriction on later on. A message on aneuploidy screening: because we've had triplet pregnancy, we don't do all these double and triple marker tests in the early part of the gestation. What do we do after that? This was Mrs. S, who has undergone selective reduction for a TCTA triplets at 12 weeks, and we reduced one fetus, and the patient came back to us at 20 weeks with a triple screening test report which said low risk for trisomy 21 but high risk for neural tube defects, and the lab technician had put a note, high AFP mom, advised the confirmatory testing. So post fetal reduction, no form of biochemical screening or cell-free DNA or NIPT screening must be done because the values would be completely rendered spurious by the post-FR concept test tissue. The high AFP levels are due to the reduced tissue releasing these products. So this has given a false positive risk for neural tube defects, and hence no form of aneuploidy screening by biochemistry or NIPT must be done after fetal reduction at any time in the gestation. Again, some unusual situations, counseling is very important. This was a quadruplet pregnancy in a mother who was 43 years old with an IVF. Her own embryo was done, and she was a very well educated lady. She was very keen on knowing the karyotype before reduction because she had a worry that there may be a risk of Down syndrome. Again, 4 fetuses, we can't go in and sample all 4 fetuses. So a very prudent assessment was done. What was seen was fetus B and D were on either sides of the uterus. So we did a CVS for both fetus B and D to assess the karyotype of these babies. And once the karyotype of both were done, the QF-PCR result were available in 4 days time, and if it was normal, we were able to embark upon a reduction of fetus A and C right across in between the sacs, so that we were not touching these 2 sacs, and we have given a reassurance to the family that the remaining fetuses are karyotypically normal. So we have to have in mind that we would face these kind of difficult scenarios, and full assessment and counseling is important. Sometimes we have twins like this referred for fetal reduction. This was a DCDA twin referred because fetus B had a skeletal abnormality, and this patient came for a fetal reduction. A complete assessment was done. Second baby indeed have a skeletal problem, but a cursory assessment of fetal A showed that it had an absent nasal bone and a tricuspid valve regurgitation. So before reduction, we did a CVS of fetus A, which was structurally normal, and that karyotype showed that baby actually had Down syndrome. So we actually had a twins with 1 skeletal anomaly and 1 Down syndrome. So key message: good anatomical assessment and marker assessment prior to intervention. This we didn't do a reduction, patient underwent a termination. Very similar, we have a DCDA twin. One baby had an absent nasal bone and an increased nuchal. We did CVS for both the fetuses. Both had a common anterior placenta. Separate CVS was done, and one baby had, this baby with an increased nuchal had actually Down syndrome. Patient came back at 16 weeks. That baby, the nuchal fold regressed, became normal. Nasal bone was seen. You couldn't differentiate between the babies at all. So what is key is that identifying the location of the babies prior to the reduction with respect to the maternal site location is very important, and always the same operator who has done the invasive testing should also do a reduction. We've had scenarios where someone has done a CVS and referred to us for a fetal reduction. It's extremely impossible to do that because we can't know what they have done again. So to conclude, a small note on fetal reduction beyond the first trimester: if we see a major malformation in the second trimester, say at 20 weeks the baby has got a Dandy Walker malformation or an agenesis corpus callosum or a late detection of aneuploidy, what do we do? 2 thought process: do we do and if the patient really wants a reduction, do we do an immediate reduction or a late fetal reduction? An immediate reduction carries with it around a 15% risk of miscarriage and also a significant high risk of early preterm delivery, and a late reduction close to around 32 weeks helps to reduce these risks and around 40% of these babies deliver within 2 weeks of the procedure, but still we would have a viable late baby at that point of time. To end this note on fetal reduction in monochorionic twins, it's not as simple as that. We have very clear indications. In monochorionic diamniotic twins, reduction is only done in the second or third trimester. The indications are either a selective growth restriction of one of the babies with very critical abnormal Dopplers or discordancy, or a monochorionic twin with one baby having a lethal anomaly, say having an anencephaly, or you have a twin transfusion syndrome with one baby having very less chances of survival. And when you look at these, the reduction process is done by either a process called a radiofrequency ablation or a cord coagulation. I'll just put it across a note. The outcomes are around 70 to 75% with a 25% risk of miscarriage. This was a MCDA twin with a fetal growth restriction of a 40% discordancy, and the smaller baby actually had a reversal of Doppler flow, and the mother also developed significant hypertension. And because we couldn't do laser at that time, we did a RFA, very quick procedure of 20 minutes. Maternal blood pressure reverted back to normal, and pregnancy was able to push to 33 weeks also. Again, a pregnancy with TTTS of advanced stage. You can see the severe poly and a stuck twin, and the stuck twin baby had a ductus venosus reversal at 25 weeks. So we went ahead and did a reduction of this baby by radiofrequency ablation, and pregnancy was able to go to 34 weeks. Because in these pregnancies, we can't do an intracardiac injection of KCl or lignocaine. It would cause a co-twin demise. And these are the techniques which we do. As I said, this is a bipolar cord coagulation. It's done using a fetoscopic method, and this is a cord that you can see that has been coagulated and then transected at the end of the procedure. And this is a radiofrequency ablation procedure. This is a radiofrequency needle. It's got tines. This is a machine that is involved. It goes inside the affected fetus, and the tines open, and by radiofrequency heat the affected fetus. This is actually a TTTS with a polyhydramnionic fetus having high drops, and hence we did an RFA procedure, and that enabled us to optimize the outcomes. So it's again a twin transfusion syndrome where one baby had a ventriculomegaly, hence reduction was done. So overall, when you do these procedures for a structural malformation, the live birth rate is close to 90%. When it is done for twin transfusion syndrome, the live birth rate is around 70 to 80%. So the key take-home message is that intervention by fetal reduction is done to optimize the pregnancy outcomes. A very systematic assessment is required prior to intervention. Counseling and documentation of all these is essential. You need a separate team to do this, someone who counsel and someone who does a good assessment. Patient's choice and acceptance to the procedure must be taken into account. Technique and expertise reduces the risk. Reduction in monochorionic twins is complex. It's done for very specific indications and by RFA or coagulation procedures. Thank you so much for a patient listening.
Thank you, sir. An excellent talk on fetal reduction. Thank you very much. Any queries from the audience? Would you like to present a moment or two, sir? I would like to invite Seshasai sir to present a moment or two, sir. Sudarshan sir. Next is chairpersons కదా. Thank you, sir. Sir.
Dr. Sudarshan, I'm a student of Mediscan. I'm so happy to hear you speak today. I'm an ardent follower of your dad. Sir, why do you choose the baby closest to the fundus and not the baby near the cervix? It'd be easier for the baby to abort if it's close to the cervix, right? Doesn't it disturb the other fetuses when it comes out if you choose to abort the baby that is near the fundus?
Okay, the first thing is when we do a reduction, the reduced fetus never comes out. or rather it should not come out. If the reduced fetus comes out, it means the pregnancy is going for a miscarriage. Whether it be the A fetus or the C fetus, if the other fetus has come out, it is going to end up in a complete miscarriage.
Okay.
So reducing fetus C does not increase the risk. A small subset of pregnancies, when we see that when we do a reduction, you have amniotic fluid leak that happens from the reduced sac. And what we have seen is that when we reduce the sac closest to the cervix, the leakage is slightly higher. There is no big evidence. It's clearly what we have seen from our practice, that when we reduce fetus A, the one closer to the cervix, then the post-reduction leak and the post-reduction spotting or bleeding is slightly higher, and which is why we try to avoid that. And second, when we have to reduce fetus A, many a time what we see is that the other fetuses are right on top of it. The membranes of fetus B and C are on top of it. We cannot do an intervention where the needle goes through the other sacs to reach fetus A at all. So when we need to approach a sac, it's got to be avoiding the other two sacs, and reaching fetus A sac will be very difficult without avoiding the other sacs.
Even if you do it after 12 weeks also, doesn't it bleed or leak so that it doesn't affect the other? After 12 weeks.
Yeah, around 11 to 12 weeks
Yeah,
is when we
yeah.
do. CRL of around 50 to 55. That's when we have the best outcomes. Because as we have seen, right, a very huge number of structural malformations are picked up at that time. We don't want a situation of doing an FR at around 9 weeks of pregnancy and we are left with an anencephalic fetus at 12 weeks. It will be a disaster.
Okay, sir. Thanks a lot.
Thank you, sir. I thank Dr. Shesai sir and G. Lata madam for chairing the session. I would like to invite Sanjay Reddy sir to give memento to Lata madam. Thank you, sir. Thank you, Lata madam. I would like to invite Asha Lata madam to give a memento to Shesha Sai sir. Thank you, madam, and thank you, sir. Next session will start.
We'll start the next session. The next session will be chaired by Dr. Ashalata ma'am. And ma'am is the managing director at the Ashalata Test Tube Baby Center, Tirupati. We request ma'am to chair that session. Ma'am, please come on. Next, I would like to invite Dr. K. Subhashini ma'am to come on to the dais and chair the session. And ma'am is worked as a government service for 30 years and she took voluntary retirement recently. And ma'am is a lifetime member of ISER and she is the director at Subhashini Hospital, Tirupati. Thank you, ma'am.
So, snacks and tea are available downstairs. If anyone have it, please. Thank you.
Dr. Kundan Sir, he is the chairperson, Infertility Committee, Foxy 2020-23, Director of Nimriti Clinic, Center for Assisted Reproduction, Endoscopy, Pune, and General Secretary for Pune Obstetric Gynecology Society. and now he is going to talk on ovulation induction, fine tuning of infertility management. Thank you, sir. Welcome.
Thank you, and good morning, everybody. Thank you, Chairperson. Thank you very much. Thank you. Sorry for the delay. Today my presentation is on ovulation induction, fine tuning of infertility management. And to my audience, let me tell you, I'm going to focus on completely this talk to the treatment like intrauterine ovulation induction associated with intrauterine insemination. Now this is a position and this is our status as a clinician when we deal with infertility patients and especially the treatment like IUI. So, sorry. Okay, so principles of ovulation induction are majorly we have to keep it in 3 important points. One is we have to achieve a pregnancy, but in a shortest time, and that's I always feel that should be our prime objective, that we have to achieve pregnancy in a shortest time. Second, we have to avoid those complications of ovulation induction, that is ovarian hyperstimulation and multiple pregnancy. Now this is a most important slide. We are going to spend little time on this because this is going to help us to fine tune our ovarian stimulation. Now if you look at this diagram, and this is our natural cycle. So this is on the first or second day of your menses. This is what happens. The FSH is in the range of 5 to 7. Now what happens is because of the lower estrogen, the FSH is increased, and this dotted line which represents a threshold. So the FSH has to go beyond this threshold to have a follicular recruitment. So once the FSH goes above this threshold, we have 2 or 3 follicles which gets recruited in a natural cycle. Now what happens is that as this follicle starts growing, there is a production of estrogen from these follicles, and because of which the estrogen inhibits FSH release, and that's why slowly FSH goes down and then it falls below the threshold. Now once it falls below the threshold, out of these 3 follicles, couple of follicles will go into atresia, and only one dominant follicle will go in for a dominance phase or for the ovulation. Now which we need to understand, this area which is vertical dotted line is called FSH window. Okay, the more wider window you will keep, the more number of dominant follicles you will get. Okay, if you keep FSH shorter, FSH window smaller, then you will not have more than one follicle. Now most important, another principle of endocrinology is that FSH has to cross beyond this threshold for a follicular selection. So what happens in clomiphene resistance with 50 milligram, 100 milligram, so sometimes we don't get follicular selection or growth. That's because our patient's FSH doesn't go beyond this threshold, and that is why we get follicular no follicular growth, which is called clomiphene resistant. Now if you look at, this is the same principle which is used in a controlled ovarian hyperstimulation, where we use this principle in IUI as well as in IVF treatment cycle. So what we do is we give gonadotropins, especially in gonadotropin cycle, we give gonadotropins right from the start, so that the FSH goes beyond this threshold, and we give daily gonadotropins so that we keep that FSH above that threshold, and because of which we get 2 or 3 dominant follicles growth during controlled ovarian hyperstimulation. Now in IVF we start with a very high dose, and because of which the levels goes very high, and not only 3-4 but we get 8 to 15 follicular growth if the reserve is normal. So this is a simple endocrinology principle which we have to understand about ovulation agents. Now this is what we expect. We just want a adequate response, which is threshold for stimulation, but we don't want hyper response, or even we don't want no response or no recruitment. So we are looking at threshold for ovulation induction. So these 6 principles of ovulation induction, we keep it in mind. Elevation of FSH beyond threshold levels required for follicular recruitment. That's now point number 1. Point number 2, the narrow FSH window, you will get a single follicular growth. The wider FSH window will get a multiple follicular growth. Now the LH hormone acts on theca cells in follicular phase, and it produces androgens, and LH acts on theca cells as well as granulosa cells in luteal phase, and thus it produces not only androgen but also produces estrogen and progesterone. Sustained high levels of estrogen can result in premature LSH, one of the most common side effect of controlled ovarian hyperstimulation that is associated with a poor success rate. So whenever you want to do a controlled ovarian hyperstimulation, you have to look for premature LSH. Now, if there is a premature LSH, there is an advancement of endometrium receptivity. Ultimately, we are going to face implantation failure. So when you want to do controlled ovarian hyperstimulation, we have to keep LH under control. We don't want that premature LH surge, and thus we can save a success rate of the cycle. Also, clomiphene and gonadotropin induced cycles, they are associated with surely luteal phase defect, and thus these cycles, these stimulated cycle by these agents, they need a progesterone support during luteal phase. Now these are the three drugs which we commonly use: clomiphene citrate, aromatase inhibitors, and gonadotropins. So clomiphene citrate is an ancient drug. We are using it for so many years, but because of its side effect, we have many, we have started using another second line and third line, which has become a first line, which we will see. Now when you are planning a ovulation induction, first thing you have to divide your patient into two categories. The first category is a unovulatory woman, and the second category is a explained infertility. Unovulatory women will present to you with irregular delayed cycles, and unexplained infertility patients will always present to you with regular cycles. But there are other factors also for unexplained infertility, which we are going to see in the later of our presentation. Now when it is counted that success of COH and IUI depends on all these factors, and one of the most important factor is number of follicles at the time of insemination, because if you have at least 3 to 4 follicles, by a law of nature, if we have 3 to 4 oocytes, then one oocyte out of 3 or 4 will give us a competent blastocyst, which can result into pregnancy. So that means if we want a better results, we should have at least 2 or 3 or 4 follicles, then our chances of pregnancy in a shortest time is going to be higher. We know the disadvantages of clomiphene, that we have a better ovulation rate, but we have a poor pregnancy rate, and all because of anti-estrogenic effects on the endometrium and the cervical mucus. And also we know that clomiphene is associated with a higher incidence of miscarriage. So the first choice has, especially in unovulatory patients like PCOS, the first choice is aromatase inhibitors and letrozole, which we can use in 2.5 to 5 milligram once daily for 5 days, and ideally to be started from day 2, not day 5, day 2 or day 3. Now certain studies have also demonstrated that you can even use a single dose of 20 milligram of letrozole on only day 3 of menstrual cycle, has demonstrated the similar efficacy and a success rate. Now we know when we compared letrozole and clomiphene, the biggest advantage of letrozole is a short half-life, because clomiphene has got a longer half-life. It keeps on causing that anti-estrogenic effects on endometrium and the mucus for a prolonged time, and we cannot reverse it back. But that doesn't happen with letrozole because of the quick washing time. The half-life is only 2 days, and also it has been shown that the uterine blood flow is much better with the letrozole, and it is definitely poor with the clomiphene citrate, and pregnancy rates have been diagnosed are better with the letrozole. These effects has proven that letrozole is a first choice. Now if we look at the advantages, first of all, 100% bioavailability of after oral administration. As I said, rapid clearance, absence of tissue accumulation of the medication, and no significant active metabolites which remains in the circulation, and it is an extremely potent inhibitor of aromatase enzyme. Now this was a meta-analysis in 2019 for individual participant data meta-analysis for the first line ovulation induction for PCOS, and 20 randomized control trials were involved, and they concluded that in women with PCOS, letrozole improves live birth rate and clinical pregnancy rate, and the most important, reduces time to pregnancy compared to clomiphene citrate. As I said, first objective is to achieve a pregnancy in a shortest time, and that is something which, when it is compared with clomiphene, letrozole proven to be better. And clomiphene citrate along with metformin that also increases clinical pregnancy rate, but that may reduce time to pregnancy compared to clomiphene alone, while there is insufficient evidence of a difference on live birth rate. And that's why it is very important that even clomiphene citrate and metformin, when was compared with letrozole, the live birth rate was not much shown to be different or superior than letrozole. The treatment effects of letrozole are always and always influenced by what are the serum levels of total testosterone in that patient, and clomiphene citrate plus metformin are especially affected by baseline serum levels of insulin. So this is when you are using a specific protocol, you have to look these serum levels in the patients. Now this was letrozole versus clomiphene citrate. It was a randomized controlled trial in 2021. Almost assessor blind RCT 90 infertile women with PCOS. What they found was pregnancy rate, monofollicular development, mean time to achieve pregnancy significantly better in favor of letrozole. So letrozole is a better alternative than clomiphene. So now let's focus on the protocols, because we have learned certain endocrine points. We have learned about the ovulation induction agents. So how can we play with different ovulation induction protocol? Now this first protocol where we are using a letrozole, which is 2.5 milligram, you can start from 2nd day to 6th day, and then 7th day onwards you can monitor follicle. As soon as the follicle is 18 to 19 millimeter, you give a trigger of SCG and you do a single IUI between 36 to 48 hours, and then you can supplement with progesterone followed by 17th day urine pregnancy test from IUI. So this typically this protocol will give you single dominant follicle. So this is monofollicular growth protocol. Now if you want no premature LS surge, especially in PCOS patient who are very prone to have a premature LS surge. So what you can do is, this is a very older protocol, but it is still used by many European countries, that day 21 of the previous cycle we start GnRH agonist 0.5 milligram daily, and we wait for 11 days. By at the end of 11 days she gets down regulated and she gets her menses, and then we start pure gonadotropins cycle, that is recombinant FSH, either 37.5 or 50 IU. We give it for almost 4 to 5 days, almost 7 days. 7th day, if you see that the dominant follicle is not gone beyond 10 millimeter, you can step up the dose. So what you can do, if you have started with 50 IU, then you can step up to 75 IU after 7 days, and then you keep monitoring. So but the rule is that because it is a down regulated cycle, you have to give daily gonadotropin doses. That is very important. Here we can't give alternate, because otherwise the follicular growth will get slowed down. Typically again, this protocol, if your starting dose is just 37.5 to 5, you will typically get a single follicular growth. Okay, but if your dose is very higher, like 75 IU or 100 IU, you will get 2 or 3 dominant follicles. Now if you have a aim to have more than one follicle, that is 2 or 3 dominant follicles, then you give letrozole from 2nd day to 6th day, but 7th day you add gonadotropins. Now if you are using HMG, you can, depending on the follicular size, you can decide either 75 IU or 150 IU of HMG daily till SCG. Okay, so that is very important. You have to give daily gonadotropins for a faster growth of follicle, and as soon as the follicle is 18, you give SCG, and the rest protocol is same. So what happens here, you have allowed FSH to go to threshold, beyond threshold, and because you have added gonadotropins, you did not allow the later drop in FSH hormone levels, and because of which atresia of selected follicle doesn't happen. And that's why you get 2 or 3 dominant follicles which remain in the cohort, and thus we have a 2-3 dominant follicles on the day of SCG. Now this is another very important protocol, and this is, I think, the most common protocol majority of the IVF consultants and even in my practice we use, because here we want at least 3 or 4 dominant follicles. So what happens is we give letrozole on the 2nd and 3rd day only, that is 2.5 milligram, but we introduce gonadotropins right from the 4th day. So if that again depends on antral follicular count, you can decide that's whether to use 75 IU or 150. So age, obesity, previous history of OHSS, and there are many factors which controls this decision. But 4th day you start giving her gonadotropins every day. So you can give either 75 IU or 150 IU. Now you give it daily, so give for 3 days. So 7th day of menses she comes back and you do the scan. Now here we expect that she has already received gonadotropins. So we expect that her follicle has to be beyond 10 millimeter, which is in a dominant phase. So at least 2 or 3 dominant follicles you will get, and then you can continue this giving gonadotropins of same dose. Now as soon as the follicle is 14 millimeter, it is reaching that size, you can send her LH. If the LH levels are between 5 to 10 MIU, then you add antagonist at this level, because next 2 days the follicle from 14 it will reach to 18 millimeter. Typically you get 2 or 3 dominant follicles, and because of which you have a higher chance of premature LH surge, because the estrogen levels in the circulation are going to give that feedback and LH is going to release early. And so in these protocols, generally use of antagonist is required almost in 30 to 40% cycles. So keep monitoring this LH, and depending on LH levels you decide whether antagonist to be given or no. And on the day of SCG you give a last dose of antagonist and trigger by SCG, and the rest protocol is same. If you still a lover of clomiphene citrate and you love to use that, you can still avoid a side effect of clomiphene, where again the similar protocol, you can give only clomiphene on 2nd and 3rd day, but 4th day you add gonadotropins. Typically the clomiphene washout time period is 5 days. So by the time 7th day clomiphene effect has gone down, so we don't get that endometrial or cervical mucus anti-estrogenic side effect, which is it is a major reason for failure. So even this protocol is popular with clomiphene citrate with gonadotropins. Now if you want to use a pure gonadotropins, as we discussed in down-regulated cycle, but you give 1 cycle of OC pills, especially for those PCO patient who's got a reverse FSH LH ratio, you give 1 cycle of OC pills. 2nd day you directly start with gonadotropins of 37.5 to 75. I always recommend start using from 50 IU, because otherwise with 37.5 you end up in giving more gonadotropins for more duration of time. So start with 50 IU, and quickly after 4 days you can step up. Don't wait for 7 days in pure gonadotropin stimulation cycles, which are non-down regulated. So you can give 4 days, call her on 5th day, look at for dominance. If there is a dominance, don't change the dose, continue giving that dose. Suppose you see one dominant and one or two smaller follicles, like one is 12 but others are 9-10 millimeter, you want to step up those smaller follicles, then increase the dose, because remember the smaller follicles are going to consume more gonadotropins and a larger follicle is going to consume minimal gonadotropins, and then they catch up the growth, and you really after 2 days you see that 3 follicles are in the same size. So remember these principles. Gonadotropins for ovulation induction, there is no difference in the literature in terms of live birth rate or incidence of multiple pregnancy or clinical pregnancy rate or miscarriage rate when urinary gonadotropins were compared with recombinant FSH. So any gonadotropin is absolutely fine, but the evidence has proven that if you use HMG, it is associated with the lowest chances of ovarian hyperstimulation and even the lower chances of miscarriage. That was proven by Megaset HR trial. HMG is the first choice in PCOS patient. Now combining oral ovulogens with, as I mentioned, those last 2 protocols, that you use oral ovulogens for 2nd and 3rd day and then add gonadotropins. Here what we achieve is we reduce the consumption of gonadotropins, so it is become a least expensive cycle. So if you look at the comparison, if you with these drugs like letrozole with gonadotropins or clomiphene with gonadotropins, then clomiphene with gonadotropins has associated with cycle cancellation due to OHSs almost in the range of 5.7%, but if you use letrozole with gonadotropins, absolutely 0% OHSS risk. And that is why it is important. The first choice with this evidence is letrozole and HMG. Again, if you look at it, if you compare letrozole with HMG and compare with clomiphene with HMG and HMG cycles, if you look at cycle cancellation rate due to hyperresponse, it is lowest with letrozole with gonadotropins in comparison with CC with gonadotropins or pure gonadotropin cycle, and that is very important. And again, if you look at the duration of treatment, it is shortest with letrozole with HMG. So this was our observational study into our own patients. I'll go quickly to the results. So this you can, I'm talking about letrozole on second and third day, and fourth day you introduce gonadotropins. That protocol, when we compared into our patients, we found that implantation rate per cycle, per one cycle, you can have almost 26% pregnancy rate with these kind of protocols. Now, if you look at miscarriage rate, it is only 9%. So in a general population, the first trimester miscarriage rate is 10%. So it is not increasing the miscarriage rate if you compare with the general incidence. If you look at per patient pregnancy rate, if you look at cumulative pregnancy rate per patient, almost in the range of 31%, which is, you can really achieve these results, but you have to remember these endocrine principles which we discussed, that use letrozole with gonadotropins, monitor LH. If the LH is high, use antagonist and give it a trigger at the right time. And none of these patients had a mild to severe ovarian hyperstimulation. But with this protocol, you have to remember that slightly higher twin pregnancy rate is going to happen. That was in the range of 24% we documented into this group of patients. Now, when to administer SCG, most important is if you administer SCG at 18 to 19 millimeter, 90% chance that your follicle will yield mature meiosis 2 stage oocyte. So 18 to 19 is ideal, and that should be sufficient. There were some incidents reports that if with clomiphene or you wait the follicle till goes 22 millimeter and it gives much better results. But there are two schools of thought, and I feel the evidence is in favor that you follow what is been followed since last 3 decades, that you give 18 to 19 millimeter and you will get a M2 oocyte, chances are going to be higher. We have understood ovulation induction in unovulatory women. Let's understand quickly about unexplained infertility. Now, unexplained infertility definition is very clear, that a patient has tried for minimum 1 year if she is less than 35 years old, or if she is more than 35 years, she has tried for minimum 6 months and she has not conceived, but she has a regular cycle, so ovulation naturally is happening. The tubal patency has been confirmed by HSG, and semen analysis is normal. That's the definition of unexplained infertility. So the practice committee of ASRM in 2020 recommendation says that such kind of patients, you do 3 to 4 cycle of oral ovarian stimulation cycle with IUI, and if they fail, IVF is recommended rather than ovarian stimulation with IUI with gonadotropins. Now that's very important. Once you do 3 cycles for unexplained infertility, don't continue more than 3 and shift her. If she doesn't conceive, shift her to the IVF. Now we'll understand the evidence. Now it has been shown that in these patients who are regular cycles, clomiphene citrate with IUI is the first choice. Remember friends, first 3 cycles should be in unexplained infertility. The incidence, the literature supports clomiphene is the first choice, and you can use letrozole with IUI. It has got a similar efficacy, but remember, for unexplained infertility, FDA doesn't allow you to use letrozole. That is the only drawback. But letrozole can be also a good drug. Not recommended to use letrozole or clomiphene citrate plus conventional dose of gonadotropin. So that combination of oral ovulogens with injectable is not allowed. So this was a fast track trial which compared this previous protocol where you use oral ovulogens followed by gonadotropins, but in accelerated arm you are using directly putting the patient after 3 failed cycle into IVF, and the per cycle pregnancy rate with this kind of fast track trial, almost you can achieve 30.7% into unexplained infertility. So just to summarize my talk, letrozole first choice, letrozole with HMG ideal to achieve a pregnancy rate like 27% per cycle or 31% per patient. And remember, keep a watch on premature LH when you are using both the drugs together. Slightly higher multiple pregnancy rate achieved with those combinations. In unexplained infertility, clomiphene induced cycle first choice, do 3 cycles. If she doesn't conceive, ask her to undergo IVF rather than doing more IUI cycles with gonadotropins. So friends, success comes from knowing that you did your best to become the best that you are actually capable of becoming. So thank you very much for the patient hearing, and it was a lovely coming all the way to Tirupati, and we had really good darshan in the morning, and I think because of which I was late. I'm so sorry for that, and thank you very much once again.
Thank you, Kundan sir. In right time, you completed a very nice talk. And finally, the take-home message given by sir is, we are in a confusion to use clomiphene or letrozole. Finally, he gave me that letrozole is better to have a live pregnancy rate because no action on the endometrium. And also, very nicely, we are not at very thorough with the using of antagonist in IUA cycles if we had a multifollicular development to avoid. So it is very nice talk, sir.
Thank you
Sir,
so much.
one question. If
Please.
we stimulate along with this gonadotropins, if we had multifollicular development, if more than 3 follicles, can we cancel the cycle or we can control
No,
with?
I'll tell you, if you have given letrozole on second and third day, and fourth, fifth, sixth day, you have added gonadotropins, say you have started 150 IU, okay? So seventh day when you scan and you see more than 3 or 4 dominant follicles, please use a step down protocol. So reduce the dose from 150 to 75, and because of that reduction, the FSH level falls. Again, we are using the same concept of endocrine. So what happens, another 2-3 follicles which are in the cohort will go into atresia, and only 1 or 2 follicles will remain. So in such scenario, rather than cancelling, step down the dosage of gonadotropins, and you will see that the certain follicles are not going ahead and only few 1 or 2 are going ahead. So step down is the answer for that.
Yeah, thank you, Dr. Kundan, for the detailed explanation of ovulation. One thing, because all the methods of ovulation explained by you clearly, one thing, before starting the ovulation, induction of ovulation, first of all, we have to select the patient into 3 groups. As we all know, that 3 groups are poor responders, normal responders, and hyper responders. And so, according to that poor responders, normal responders, and hyper responders, then we can select the method of induction of ovulation that will be apt for this topic. Thank you. Thank you.
Thank you very much.
Now, I request Sukanya Seshai Madam to honor and award to Kundan sir.
It's my pleasure to invite Dr. Rakesh Kumar Sahe. He is professor and head of the Department of Endocrinology, Usmania Medical College and Hospital, consultant endocrinologist, Sahe's Endocrine and Diabetic Center, Ameerpet, Hyderabad. He is president of Endocrine Society of India, vice president South Asian Federation of Endocrine Societies, and section editor of Tropical Endocrinology, Endotext online textbook of endocrinology, editorial board member of IJEM, and National EC member RSSDI, Organizing Secretary RSSDI of National Conference 2016. He got many awards. So, Fellowship of National Academy of Medical Sciences 2021, Fellowship of American College of Endocrinology in 2009, Fellowship of RSSDI in 2015, Fellowship of the Indian College of Physicians in 2006, Fellowship of Indian Academy Clinical Medicine 2008, and a host senior lectureship oration of Association of Physicians of India for 2008, and Best Teachers in Medicine Award from Government of Telangana for 2018 on Teachers' Day. Publications, over 150 publications in various national and international journals he gave, and authorized chapters in various textbooks and monographs on diabetes and endocrinology. So it's an honor to invite Dr. Rakesh Kumar Sahe to give this lecture today.
Thank you, madam. Am I heard then?
Yes, sir. Yes, sir.
Can you hear me, madam?
Little bit louder, please.
Okay, thank you, madam. Thank you for the kind introduction, and I thank the organizers for inviting me to be here today. And sorry, I'm very sorry that I'm not able to personally join because of some urgent work coming up. I had to stay back, and therefore I am not able to join. But I will try to cover the topic which is given to me about management of diabetes in pregnancy, the global pandemic. So I think in this conference we had in the morning we had a talk by Dr. Balaji, who has spoken about who has discussed about the screening for gestational diabetes, and I will be speaking about diabetes in pregnancy on the entirety with particular focus on the management aspects. So if you look at hyperglycemia and pregnancy, there is a significant increase, and this has become a global epidemic, as has been rightly labeled in this conference, that it is a global epidemic. And today it has not only importance to the woman itself who has got this problem, because it has effect on the health outcomes of the mother and the child, but also it is of public health importance. Because because we are saying that this entire epidemic of diabetes and non-communicable disease like heart disease, hypertension, lipid abnormalities, all this can be attributed to gestation, to diabetes in pregnancy, that is to hyperglycemia and pregnancy itself. And prevention therefore of these problems like diabetes should start in utero and should continue throughout life. So that is the importance of this issue of managing hyperglycemia effectively during pregnancy. It's one of the most common medical conditions, and 1 in 6 live births occur to women who have some form of hyperglycemia. And if you look at the entire broad umbrella of hyperglycemia in pregnancy, you can say 84% of this is because of GDM, and the remaining is because of pre-existing diabetes. So this slide shows us that today we can say that global prevalence of the problem is about 16.7%. Number of live births affected is 21 million across the globe every year, and 80% of this are because of GDM. 10% of them are because of diabetes which is detected prior to pregnancy itself, and 9% are due to diabetes which is detected for the first time in pregnancy. So this has to be differentiated from GDM. GDM is which is detected in the second and third trimesters, and where the levels are in the dysglycemia range, whereas those which are very high are diabetes detected in pregnancy itself. You can call them as overt diabetes in pregnancy. Now, if you look at the different IDF comes out with atlas every 2 years, and in the 2001 atlas they said that they have the Southeast Asian region is ranked highest in terms of the number of people who are affected, number of live births which are affected because of hyperglycemia. And this has been increasing over the years, and as you can see on the right side of the figure, those at older ages, women at older ages are affected more than women at younger ages. And if you look at this hyperglycemia and pregnancy challenge as is depicted by FIGO, what they have said is that the 21 million, like the larger circle is 21 million people who are affected by women who are affected by hyperglycemia during pregnancy. Out of this, the important aspect is that only 3 to 4% are actually reached out by us. We are able to screen and detect only in 3 to 4 million, and the remaining, and out of that also only a small percentage are actually getting proper antenatal care and postpartum follow-up. So this is how what we are saying is that there is a huge problem. We have to do much more, and what we see is that more than 65 million deliveries are happening in our region, that is India, China, Pakistan, Indonesia, Bangladesh. So this part of the world is taking care of is having the maximum burden of hyperglycemia and pregnancy. So it's a slow moving problem where we are all saying that this is all leading to non-communicable diseases. And we know that this concept of gestational diabetes was first described by Priscilla White in 1950s, and she gave the White's classification that is still used today to distinguish between, particularly for pre-gestational diabetes, type 1 diabetes. We use that system of classification. But coming to hyperglycemia in pregnancy, what we now say is that we categorize between pre-gestational diabetes, gestational diabetes, and diabetes in pregnancy. So which can be seen in this figure. What we are saying is that when you're looking at diabetes in pregnancy, it can be those which are diagnosed before pregnancy, they are called pre-gestational diabetes. They can be either type 1 or type 2. Then those who are diagnosed for the first time during pregnancy as diabetes, overt diabetes, are again type 1 and type 2. And then we have the category of gestational diabetes. So gestational diabetes is basically hyperglycemia during pregnancy that is not high enough to be categorized as diabetes, and hyperglycemia is diagnosed for the first time during pregnancy. It can occur any time during pregnancy, but most likely after the second trimester. Whereas diabetes in pregnancy can occur at any time, and what we are saying is that these values here are higher than the cutoff values used for the diagnosis of diabetes outside of pregnancy. So same values when you use in pregnancy also, then you call it as diabetes in pregnancy, and that can be pre-gestational diabetes or diabetes detected for the first time in pregnancy itself. Now, just to look at the differences between these two, what we say is that diabetes, if you look at diabetes in pregnancy, it is the degree of hyperglycemia is higher as compared to the milder hyperglycemia which is seen in GDM, and the complications are also there. Here what we have to understand is that they have the risk of complications of diabetes which is not there in GDM, because the woman herself doesn't have those complications, whereas a fetus is at risk. Whereas in the a woman who has got pre-gestational diabetes or diabetes in pregnancy, what we are saying is that we are worried about the complications of diabetes. We are also worried about the embryopathy and also the risk of spontaneous abortions, IUGR and IUDs, which are not the case in GDM, where we are worried more about macrosomia, difficult labor, and maternal neonatal risks of future type 2 diabetes. So just quickly to just briefly go through the pathophysiology of GDM or diabetes or hyperglycemia in pregnancy, we can say that if you look at the physiological changes in pregnancy, we know that there is an increase in insulin resistance during pregnancy because of the production of progesterone. Various pro-inflammatory and insulin factors which increase insulin resistance, like progesterones, decrease in adiponectin, human placental lactogen, TNF alpha, all these go up during pregnancy. They lead to increase in insulin secretion. Normally this is what happens, and the balance is maintained, and the purpose of this is to facilitate nutrient supply to the fetus. While maternal insulin resistance favors that, it alters the nutrient and energy metabolism in the mother itself, and the insulin secretion matches to take care of that. But in women who have got a predisposition for gestational diabetes, they have absence of this, and because of that, what happens is that they tend to develop gestational diabetes. And these are women who are programmed to have who have lesser beta cell mass. They don't have compensatory hypertrophy of the beta cells, which happens in normal individuals. So what we see is that this is why gestational diabetes develops. But if you look at those with pre-existing diabetes, that is type 1 diabetes or type 2 diabetes, there are certain changes which are happening during pregnancy. What are those? The fasting blood glucose coming down because by the 8th week, reaching the nadir at 12 weeks. Early pregnancy, there is increase in insulin sensitivity in early pregnancy, but in later part of the pregnancy, insulin resistance increases, as we just saw in the previous slide. And there is increase in free fatty acid production, which serves as a fuel for the maternal metabolism, with diversion of glucose to the fetus. And glucose and amino acids are diverted to the fetus. Ketones can cross the placenta and serve as an alternative fuel for the fetus also. But free fatty acids serve as the main fuel for the mother. Now, if you look at what happens, what crosses and what does not cross to the fetus, we know that glucose, small molecules like glucose and ketones and amino acids cross freely through the placenta, but larger molecules like insulin, glucagon, they do not cross the placenta, and so therefore whatever insulin is given to the mother doesn't cross the placenta, but the glucose itself, the amino acid itself can increase the fetal production of insulin and can cause all the problems that happen in gestational diabetes. So what we are saying is that during pregnancy, this Frenkel's hypothesis is coming into play, which we are saying that what happens is that because of the increased plasma glucose, amino acids and lipids which are happening because of decreased insulin secretion, they cross to the placenta, cause increase in insulin secretion in the fetus itself, and that can lead to macrosomia, that can lead to neonatal problems like obesity in the neonate, hypoglycemia, hypocalcemia, and even hyper increased in red cell count and other problems that happen in the fetus, and later on can lead to IGT and GDM much later. So this basically, I think I've just discussed this, so I'll not go into details of that. But what I would like to say is that the presence of pre-gestational diabetes has significant impact on the maternal health. It can lead to alteration in fertility, I mean impaired fertility. Miscarriages are quite common in women who have either IGT or diabetes prior to pregnancy, and also those who have got PCOS, which is again a pre-diabetic condition, and because of that there are increases to congenital malformations if the glucose levels are high during the first trimester of pregnancy, and these are the characteristic congenital malformations which are seen in pregnancy, and in the later parts when gestational diabetes develops, we are looking at macrosomia and stillbirth, I mean and other problems, the fetal morbidity that we are looking at. One word about diabetic retinopathy. This is particularly important in pre-gestational diabetes, to screen for retinopathy prior to conception and also during each trimester of pregnancy, because there can be, because of the changes that happen during pregnancy, there is increased placental growth factors, increased permeability of the retinal epithelium, and that can lead to macular edema, decreased retinal blood flow in the third trimester, causing retinal hypoxia. So therefore this is something which has to be looked into in women with pre-gestational diabetes, while in gestational diabetes this is not required. Similarly, diabetic nephropathy can progress during pregnancy. That is something which has to be followed up. Neuropathy also has to be followed up, particularly those who have got autonomic neuropathy in the form of gastroparesis, hyperemesis, they can go into decay. And the macrovascular complications also, if they are present, if there is any degree of macrovascular complications, they can progress during pregnancy. So it's very important, preconception management, very important. Briefly, just to mention that, we need to educate patients about preconception counseling, which is very important part. And they should achieve a good HbA1c control of less than 6.5 and even 6. If it is below 6, that is even better. Establish a healthy lifestyle and a diabetes management plan which can be followed during pregnancy, and screen for diabetic complications, as I just mentioned. That is the other important component. And encourage weight loss in overweight and obese women. This is particularly important, and discontinue harmful medications like ACE inhibitors or ARBs. This is particularly important, which we have to keep in mind, because we see a lot of young women with hypertension today, young diabetics who tend to have some amount of hypertension, and we need to be careful that we avoid using these medications. And the glycemic targets that we are looking at during pregnancy are therefore a preprandial glucose level of less than 95. 1 hour after the start of the meal, it should be less than 140. While some of us would say that less than 90 is preferable rather than less than 95. At 1 hour after the start of the meal, it should be less than 140, and 2 hours after the start of the meal, it should be less than 120. Then during pregnancy, we need to look at various aspects, that is the monitoring of the A1C, monitoring of the TSH, and if particularly if the woman had hypothyroidism prior to pregnancy. But if even without that, we need to do one screening during pregnancy in the first trimester itself, and look at other various parameters that are listed out here. So the goals, as I said, are to keep a HbA1c less than 6%, 2 hour value of less than 120, 1 hour value of less than 140, and at the same time we should avoid hypoglycemia. This will help in ensuring a birth weight between 2.5 to 3.5 kgs. Now, monitoring of very important. Self-monitoring of blood glucose is what is the mainstay of treatment, and that can be done more than 3 times per day, is important, mandatory to be done. And however, it is difficult in our setup, but it is very important for attaining the glycemic values that we are looking at. And HbA1c can be done if it is done. It has its fallacies, it has its limitations, but if it is done, it can be done on a monthly basis rather than a 3 monthly basis as you would do outside of pregnancy. The other important parameter that is coming up for monitoring is the continuous glucose monitoring, where we we look at the time in range, we are looking at a timing in range of more than 70% is what we normally consider. In pregnancy, what we do is we change the goals itself. We put the range as 63 to 140, and we want more than 90% in that time, in that range, and less than 4% below range, and less than 1% below 54, less than 4% below 63, and also we want to see that we minimize the time above range also. Now, what are the management components that we are to look at? We are to look at behavioral changes, lifestyle changes, and whenever required, insulin has to be added. Metformin and glyburide have been used as, but are not preferred as the first line agents. They can because of several factors that I'll be discussing in the subsequent slides. But other oral agents and non-insulin injectable glucose lowering agents lack long-term safety, and they are not preferred to be used during pregnancy. About metformin, when it is used to treat polycystic ovarian syndrome and induce ovulation, it should be discontinued by the end of first trimester, after the end of first trimester, because it does not seem to protect against GDM. Now, medical nutritional therapy is most important. The important points about this are that all these can be individually, you can discuss for long hours on all these aspects, but I am just briefly discussing some of the important aspects. So, if you look at the carbohydrate intake, we should see that women get at least about 175 grams of carbohydrate. Avoid simple carbohydrates, use more of the complex carbohydrates. At least give 71 grams of a good protein intake, and a high intake of fibers. The saturated fat and trans fats should be reduced. MUFA and PUFA should be increased, and the carbohydrate intake should be limited to about less than 40, in the range of 40 to 45% of carbohydrate should be the carbohydrate intake which we can allow these women to take. And at the same time, we should see that they are in the form of three small to moderate size meals, and 2 to 4 snacks in between these meals. And 70 to 80% of GDM women can be managed on this alone. While for pre-gestational diabetes, all of them have to be on insulin, whether type 1 diabetes or type 2 diabetes, all of them preferably would be on insulin. While for gestational diabetes, 70 to 80% would be managed by lifestyle changes itself, and the rest of them, if they are persistently high glucose, they are not meeting the targets which you mentioned, that is the fasting level of more than less than 90, or a 2-hour post value of less than 120. If they are not meeting that within 2 weeks, then they should be put on insulin. Now, the weight management is another issue which you should see, that those who are obese or overweight it should be seen that they gain lesser weight. They are educated about that. They do not need to gain more weight. The Institute of Medicine has come out with a recommendation, and this recommendation is seen in this slide. Now, exercise is also simple exercises such as walking for 10 to 15 minutes after each meal can improve the glycemic control and are to be recommended. And the overall activity over a week should be about 150 minutes of physical activity every week. Then coming to pharmacotherapy, as we said, that if women are not under control for 2 weeks with these lifestyle measures, then they should be advised pharmacotherapy. Preferably insulin. Oral anti-diabetic medications are also like metformin is approved by our government guidelines. I will speak about both glyburide and metformin and tell a few points about these two drugs. Like glyburide is or glibenclamide, which is it is known as glibenclamide in our country, glyburide in other parts of the world. It's the same molecule, and that is preferred because it has greater plasma protein binding. It causes less transfer to the placental transfer. But still, what we see is that glyburide in the umbilical artery is seen in 50 to 70% of the maternal blood concentrations are seen in the umbilical artery, and it has, in various studies, it has failed to show non-inferiority to insulin and metformin based on composite hypoglycemia, hyperbilirubinemia, and macrosomia. Although there are studies by Langer et al. Who have shown that glyburide or glibenclamide is safe during pregnancy, and they have shown many benefits of that. But overall, if you look at a meta-analysis of all the studies, we see that it does not show a non-inferiority. It means it is inferior to insulin and metformin in terms of these aspects. and long-term safety data is also not available. If you look at the studies here, you can see that Langer study and all the other studies, if you look at it, what we are seeing is that there is a higher risk of hypoglycemia in the neonate, and also there is an increased risk of macrosomia and ICU admissions for the neonate. Now coming to metformin, so therefore we don't prefer using glibenclamide in our setup. What we use is metformin. Metformin freely crosses the placenta. It achieves concentrations which are about 40 to 50% of the concentration in the mother, and the effect of metformin on fetal insulin resistance is not known. It is used in doses of 500 mg OD or BD, which can be increased up to about 2 grams. Or some people, the maximum dose is 2.5 grams, but we would prefer not to use more than 2 grams. And several reviews have shown that it is associated with lower risk of neonatal hypoglycemia and maternal weight gain. And it is a category B drug. All drugs in pregnancy are category B drugs, as all of you are aware. Several studies on women with PCOS and type 2 diabetes show that metformin may increase ovulation, reduce the development of GDM, no teratogenicity noted, and metformin, however, has failure rate of 10 to 46%, means about half the patients who are taking metformin will require insulin sooner or later. And it has been tested in MIG trial, where it was shown that it helps in, it is similar to the outcomes were similar to insulin. The metformin group gained less weight, lost more weight by 8 kgs postpartum, but the problem was that in the follow-up there was some problem, which I'll show you in the next slide. But while we look at the MIGHTY study is another study which looked at which looked at again the use of metformin during pregnancy, and what they said was, along with reduced maternal weight gain and insulin dosage and improved glycemic control, the lower adiposity and infant size measurements resulted in fewer large infants, but a high proportion of small for gestational age infants. Understanding the implication of these is important. So what they are saying is that we are worried about all the time. We are worried about of large babies in a woman with diabetes. But here we are ending up with smaller babies, and these smaller babies, what was seen in the MIG tofu study was these smaller babies ended up being larger at 9 years of age, and whether this has an impact on the future outcomes is something which is not yet understood. So ADA therefore recommends that metformin should not be used in PIH or. Yeah, I'll just finish in another few minutes. I'll come out to insulin now. So the insulin is a sole agent which is preferred for type 2 diabetes. None of the currently available insulins have shown to cross the placenta, and there is no specific recommendation for a particular regime over others. So the most commonly used regimes are using basal bolus therapy for women who have got pre-gestational diabetes, type 1 diabetes particularly, and those with type 2 diabetes also may require that. Hybrid closed loop pumps systems have also been used in some women, particularly those with type 1 diabetes prior to pregnancy. Now if you look at the different insulins that we have, these are the different insulins that we have. Regular insulin is the one which we commonly use, NPH is the one which we commonly use. These are the regular conventional insulins. Now we have analogs like aspart, lispro and glulicin, which have been studied, particularly aspart and lispro have been studied in pregnancy, and they have been given category B status. Then we have got detimir, which has been studied in pregnancy, glargine, which has been studied but still has category C, detimir is category B. So these are all the insulins that are available. We have short acting, for GDM we use only short acting insulin because predominantly postprandial hyperglycemia is present. For those with pre-existing diabetes, we look at using we use at looking basal bolus therapy with three shots of regular insulin or the lispro or the rapid acting insulins, and a dose of basal insulin which can be either NPH or can be detimir. Now then we have got premixed insulins also, premixed analogs also available. So the advantage of that is they provide convenience of lesser doses, but they have certain problems. They may not provide as good glycemic control as is provided by the basal bolus therapy. So pre-existing diabetes and 10 to 30% of GDM need insulin. The remaining of the GDM are managed with diet alone, as we discussed in the previous slide. Pre-existing diabetes, hypos are very common in the early weeks, so we need to be careful of that and reduce the dose in the early part of pregnancy, and later part of pregnancy the requirement goes up, and the dose requirements generally are 0.7, 0.8, 0.9 units per kg. This is in the pre-gestational diabetes. Not in gestational diabetes. Gestational diabetes, the requirements are lesser and they have to be titrated based on the glucose levels. And what we see is that this is again listing out the requirements during pregnancy. When you're starting off in pregnancy, you may start off with 1/3, 2/3, but what we see is that it is best to go with the glucose levels, monitoring the glucose levels and deciding the dose. So we need to fix the fasting first and then look at postprandial coverage, and each unit of short-acting insulin covers the glucose rise which happens with 10 grams of carbohydrate. So this is what has been seen, that it has in a randomized controlled trial, conventional MDI, that is multi-dose insulin or basal bolus therapy, was not superior to twice daily premix regime also, or they also looked at the analogs also. There are some benefits of analogs, that they provide they are providing similar immunogenicity as human insulin, but they provide better control of the postprandial glucose level. So therefore they may be beneficial in some women with and this safety has been shown in several meta-analysis, and therefore they are recommended for use during pregnancy. So better postprandial control, less risk of hypoglycemia, greater patient satisfaction, no risk of progression of retinopathy or nephropathy. And the two analogs, the short-acting analogs, are aspart and lispro, which can be used, and these are recommended by most of the organizations across the world. So as you can see, only glargine, glulicine and glargine are in the C category. Degludec is also in the C category because we still don't have enough data on that, but the other insulins are in the B category. And glargine somehow has been there for a long time, it has been studied. So what is said is that people who are already on glargine can be continued, while those who are not on insulin should not be started on glargine during pregnancy. Now one word about the management of hyperglycemia during steroid therapy. We need to increase the night dose of insulin on the day one itself. As we know that steroid therapy betamethasone may be given for 2 days, and when you're giving it on the first day itself, you require to increase the night dose by 25%, increase all the doses by 40% on day 2 and 3. By day 4 the requirement comes down. Again you need to rapidly bring the insulin doses back to the pre-betamethasone days. And I'll just quickly skip over this and just say that during labor and delivery, it's important to maintain the glucose levels between 72 to 126, and for all women, whether it is overt or gestational diabetes. And we should encourage breastfeeding and take care of not forget about these women after delivery, because we should screen for the recurrence of diabetes, and also or persistence of diabetes, and also at 6 weeks for subsequent development of diabetes, and we also screen them for postpartum thyroiditis. So finally, I'll end with this, saying that women planning pregnancy women with diabetes planning pregnancy should be counseled about maintaining strict glycemic control. They should be screened for the presence of complications. Pre-pregnancy initiation of insulin and continuation during pregnancy is essential. For those who are not having a pre-gestational diabetes, universal screening for diabetes during pregnancy is very important, and that has been separately discussed, so I didn't go into the screening aspects. Maintaining glycemic targets very essential to optimize maternal and fetal outcomes, and postpartum adjustment of the doses of insulin and shifting to OAD may be required. Following up for the postpartum in the postpartum period is very important to prevent the subsequent development of diabetes in those who had gestational diabetes. Thank you all for the patient hearing.
Thank you very much, sir. You had given very good take-home points. So nowadays the gestational diabetes cases are increasing very much. So screening, instead of doing routinely at 24 weeks, it is better to do before conception and the first trimester itself. What is it?
Yes, ma'am. Absolutely, ma'am. In fact, the Government of India guideline also, and from the DIPSI also, what has been recommended is that the screening should be done at the first antenatal visit itself, because there is a high prevalence of pre-gestational diabetes in our population, and we see that many women are not detected. If we don't do it at that time, we may not do it later on till second or third trimester, because during that period, woman is at high risk of having the problems because of hyperglycemia. So screening at the first visit is mandatory, and this is recommended not only by the Diabetes and Pregnancy Study Group of India, DIPSI, but also by the Government of India recommendation also says that in the first visit itself this screening should be done.
Some patients, if they are having gestational diabetes, patients are not willing to take insulin. In those cases, just by diet and regular walking and metformin, can we continue, sir?
if they are able to, as I said, that almost 70 to 80% of women with gestational diabetes can be controlled with good lifestyle advice. So if they are under control with that, then it is good. But if they are not under control, then they should be brought under control with either insulin or metformin. Metformin has limitations. Metformin can be maybe good in some women, but suppose there is significant postprandial hyperglycemia, it may not be controlled with metformin alone. Metformin may be good in bringing down the fasting glucose to some extent. So whatever it is, what is seen even in the trials is that even in the MIG trial and other trials, at least 50% of those who were started on metformin required insulin also. So we should make them aware that they may require insulin, even though metformin is started now, they may require insulin. So that is the way we have to go forward with these women.
In well-controlled cases, can we wait up to labor pains up to 40 weeks, or we had to deliver before itself, sir?
Well, you are experts in that, but I think after 39 weeks we should be watching out for inducing labor, and that's the, I think, the general practice that we follow. Well controlled, we may wait for natural onset of labor.
As obstetricians, the first visit itself, whatever may be the 6 weeks or first visit of antenatal itself, will go for blood sugar estimation. And then definitely this glucose challenge test is helping a lot at 20 to 24 weeks with 50 grams of glucose with after 1 hour estimation. That's very helpful. And again GTT also, that is 75 grams with 2 hours estimation and 3 hours, 100 grams with 3 hours estimation. So all these things by 20 to 24 weeks we are able to detect this GDM, or basically if they are diabetic complicating pregnancy, right from the beginning we have to maintain. But regarding the drugs we will take, the management we will take, nowadays the diet control is playing major role, and apart from it, this metformin, the insulin, as we all know, insulin is the drug of choice. It won't cross the placenta, but the metformin, recently metformin, it crosses the placenta, but we are taking maximum advantage with metformin from the first trimester itself. We are giving for diabetic complicating pregnancies and GDMs also. So this metformin, because it crosses the placenta, it is reducing the hyperglycemia and it is reducing the macrosomia of the baby, and also it is reducing hyperinsulinemia and giving advantage to the delivery. After delivery also we are seeing that neonatal hypoglycemia is not there with metformin. So this metformin is well supporting the pregnancies. But if it is necessary, we are using insulin with metformin also, combinations we are using, and because we can avoid. Whereas this glycerides, we cannot use the glycerides because immediate hypoglycemia and congenital malformations and macrosomias, all these things will be with the glycerides. And now at present, as practitioners, we are using more metformin right from the first trimester, and if necessary, we are adding insulin also. Thank you, Dr. Rakesh, for the excellent message.
One point, madam. You have very well summarized everything that I said.
Yeah.
But just 2 points which I want to say is that we are not following the two-step method for screening, madam. We are advocating a single step of doing a 75 gram glucose. We don't want to do the 50 gram glucose load challenge,
2
or
hours
load, whatever you call
estimation.
it. We are doing only 75 grams, one single step test, and 75 grams. Look at just the 2 hour value. That is also good enough by as per DIPSI and as per the Government of India guideline. If you want to do if you have facilities of doing a fasting 1 hour and 2 hour value, do go ahead and do it. That may help you to look into the IAD PSG criteria also. But based on our facilities, we should at least do a 75 gram glucose and 1 hour value, one value at 2 hours. So that is important thing. And
that is we are following.
I would like to say yes, ma'am. I just wanted to add these points to what you summarized.
So
the second thing is that about metformin, I am just saying that metformin, what we are saying is what all the points which you said are absolutely true. But only thing is, on the long term follow up, what was seen was that as we are saying that the birth weight is lesser and all that, but this has led to greater fat gain later on in life at 9 years in the MIG tofu study. So that's why we are saying that we need to watch out for these children, how they grow up into adulthood, and whether they have more of diabetes or less of diabetes or more of cardiovascular disease. That is something which has to be looked at. We are not very sure about that right now.
Yeah, good doctor, because giving 75 grams and estimation more than 140, that is the estimation greater than 140 we can consider. Yeah, nice doctor, nice explanation. And one more doctor wants to talk to you.
Sir,
Yes.
why you want to stop metformin at the end of first trimester? One question. Second question, what are the various protocols to give insulin, sir, for a pregnant patient if she is over diabetic?
Yeah. So first thing is about metformin, madam. Metformin, if the woman does not, this is about women with PCOS who are on metformin, who are continued till in the first trimester, because that helps in reducing the first trimester early abortions. But it does not reduce the development of GDM. So this woman who has not developed GDM, we stop metformin. But those who have developed GDM, if you want to continue metformin, you can continue if it is managed with metformin alone. Otherwise, you may have to add insulin. Second thing is about the insulin protocols, madam. What we are saying is that if you have a pre-gestational diabetes, somebody with type 2 diabetes or type 1 diabetes, type 2 diabetes also with oral agents, if they are on oral medications, we would still prefer to shift them to insulin pre-pregnancy itself. Prior to conception itself, we'll shift them to insulin and continue with insulin, because we want to maintain good control during the peri-conceptional period to avoid malformations and all that. And type 1 diabetes, certainly they have to be on insulin. Now, gestational diabetes, those are detected during pregnancy. Many a times they are controlled with oral, with diet alone. But if they are not controlled with diet, then we look at the glucose pattern. That is, if they are having only postprandial glucose levels, which is there in most of the patients. That is, if their fasting is normal, but their post lunch or post dinner is high, say going to 160, 170, then we can give them short acting insulin with that meal, just before that meal, 4 to 6 units, and then we can adjust based on that. But if their fasting also comes high, then at that time we have to start them on an intermediate acting insulin like NPH insulin given at night, or we can even give detimir insulin in the night. And then we have to adjust these doses. So that is what is basal bolus. Sometimes we may not prefer, the fasting is also elevated. By the time the woman comes to you itself, the fasting is high, the postprandial is also high. In that situation, and she is not willing to take many doses, two different insulins, there we can use a premixed insulin, because that is convenient. By giving 2 doses, you can control both the fasting and the postprandial hyperglycemia. So that way we can give a premixed insulin also in some situations. Particularly premixed analogs we can use, where with the postprandial control will be very good. That is, premixed analogs means we have Humalog mix or no mix. Those are the premixed analogs.
Thank you, sir. Thank you so much.
Thank you, Dr. Rakesh.
As we are running out of time, we are moving on to the next talk. Sir, if you have any queries regarding the management of diabetes in pregnancy, you can inform us so that we'll clarify with sir. Thank you.
Yes, thank you. Thank you, madam. Thank you.
Thank you, sir.
Now I am inviting the next speaker, Dr. Suma Varsha. Before introducing Sumavarsha, I am very happy to introduce Suma. She worked with me in my hospital for some time after her PG. And she is MBBS, MS OBG, DNB OBG, MRC OG, Chief Consultant in 49 Hospital Vijayawada, former consultant 49 Hyderabad, ex-assistant professor at SWIMS Tirupati, MBBS at Siddhartha Medical College, Tumkur, Karnataka, MS OBG, Mamta Medical College, Khammam, and fellowship in reproductive medicine at 49 Hospital, Secunderabad, masters in reproductive medicine by IBC Medical Services, UK, certificate course in OBG, ultrasound in Stavia Center, Hyderabad, and certificate course in Ramesh Hospital, Bangalore for endoscopy, presented papers and posters at national and international conferences, published papers in national peer-reviewed journals, and contributed chapters to textbooks. So I am very happy to introduce Dr. Suma today to give the lecture as a speaker. Thank you.
Thank you so much, ma'am, for that kind introduction. So good morning, all of you. I'm very, very happy to be in front of so many of my seniors and colleagues. It's really an honor. So today I'm going to talk about the impact of the ART bill on IUI practice. So IUI, we all know, is a very simple procedure which many gynecologists will keep practicing in every corner of the country. So by the raise of hand, can I know how many of you are practicing IUI in your clinic daily? Yeah. So can I know how many of you have applied for registration? Yeah. So that is the difference. So many of us are practicing and we have not applied for the registration. So I'm just going to tell you the way forward now with the impact of the ART bill which was introduced in 2021. So the evolution of guidelines, so ART practice in India has been given guidelines right from 2002. And ever since there's been an evolution and the regulations have kept changing. So I'm just focusing with regard to IUI. So if you notice here, in 2008, a donor was allowed to donate his sample for a maximum of 75 times. And in 2014, it was a maximum of 25 times. And the age group of the couple who could procure your ART services also kept changing. So, but why do we basically need to know all these laws? So, ignorance of law is not an excuse. So, if you do a mistake and you tell them that you didn't know about it, you're not going to be excused. So, you have to know what is the right direction, what is the wrong direction, and that's important for your safe practice. So, the Parliament passed the path-breaking assisted reproductive technology regulation bill in 2021. So this is the gazette that was released in December 2021, and subsequently in January the bill was passed by the Central Cabinet, and they announced that 25th of January 2022 onwards, any clinic which comes under the provisions of the ART Act will have to follow all the rules and regulations, and the Act is in force. Now it's a full-fledged law. You have to follow it, otherwise you will be punishable. So all of us remember this Modi ji's very famous speech on 8th November 2016, where he started as Bhaiyo or Behno, and he ultimately ended up giving the note ban, right? So that was one more historical time where there was a lot of controversy, confusion, chaos, and ultimately we all settled it, and we are all fine now. So similarly with this, when this particular gazette was released also, there was a lot of confusion among gynecologists and even ART specialists for that matter. So there was a tsunami of webinars. We started sharing knowledge, we started debating, discussing as to what this act actually is and how it's going to change our practice. And major points of concern were that even clinics who do only IUI had to follow had to register and had to follow the rules. ART clinics and banks were separate entities, so you no longer can directly recruit a donor. It has to come through a bank. Only a bank can supply donor oocytes or donor sperms. And donors, you could recruit or you could take only 7 oocytes, and only the bank has to supply those oocytes in the frozen form. So ultimately, with all the brainstorming webinars we had, we realized that actually when the government is doing something to safeguard the rights of the women, we as practitioners should definitely follow suit. So it is basically an act wherein we have a national board who will standardize IUI, ART practices by standardizing the manpower, the equipment, the diagnostics. We have a registry which is a central database, which is the need of the hour right now. It gives you an excellent vision for the future research in our country, which is really at the backstage right now. And we can also curtail the illegal practices or the unethical practices like say selling of gametes, selling of embryos, or sex selective ART practices. So definitely it was a welcome change. So after all the discussions and debates, we realized that, say for example, if you don't curtail on how many times a person can donate his gametes, just imagine within no time we'll have brothers and sisters marrying each other. And as doctors we know how dangerous that could be. So we realized it was an eye-opener that these regulations were important and they needed to be in place so that we can have a safe future for the next generation. So all of the various committees had joined hands together. The FOXY, IFS, ISAR, they all came together. They welcomed the act, but definitely a few changes were supposed to be made. So they put forward to the government what changes could probably be made to the original gazette, which could make the act a little more user-friendly. So then after all the changes, a final gazette was released on June 7, 2022, and now whatever rules and regulations are formulated in this gazette have to be followed by all of us. So is there any relevance of this act in IUI practice? So now this act clearly states that ART technique includes anything where you are handling the gametes outside the human body, or you're transferring the gametes or embryos inside the reproductive system of the woman. So what does that mean? IUI definitely comes under the provisions of this act. So now the question arises as to how to register, what is the fees, how will the inspection be conducted, what is the validity of this particular act, and when do you have to renew it, what age group can ART be offered with the present act, what are the records that have to be kept, for how long they have to be maintained, what is the documentation that is required, what consent forms have to be taken. Donor gametes, whenever you're trying, what are the considerations, and ultimately what are the penalties if you don't follow the legalities. So let's try and get through these facts. So according to the ART Act, clinics are classified as level 1 and level 2 clinics. So level 1 clinics are those where only IUI is performed, and level 2 clinics are those where any other advanced ART technique is performed. And we have the ART banks who are responsible only for recruiting and supplying the donor gametes initially, and now they are allowed to recruit and supply the donor oocyte, the donor for oocytes, right? So basically we are going to be regulated by a national board, a state board, and we have a national registry which is going to form a central database. So all these boards are already in place. Even the Andhra Pradesh state board is already in place, and we've already started applying for our registrations. So this is the form which has to be filled in to apply for your ART clinic. It is available in the website. So you have to enter the credentials of your hospital, like the name, the address. You have to tell them what equipment you have, and you have to tell them what services you offer, apart from who is basically running the show, right? So for registration, the fees is 50,000 for a level 1 clinic. It is 2 lakhs for a level 2 ART clinic. It was initially 1 lakh and 5 lakhs, and thanks to the negotiations and the requisitions, it has been reduced, and they've been a little liberal about that. And once you get the certificate, that certificate of registration has to be displayed in your clinic, and it should be accessible to all your clients. So how is the inspection going to be held? So inspection can be done by anybody from the national board or state board, or any officer assigned by them. And once you have already registered, there can be any surprise inspection without any prior notice. And you should make sure that this particular inspection will not cause any harm to the stored embryos or gametes that you have in your clinic. So a copy of this entire act should be available for your clients to refer to. If you tell them now that we can't give you donors directly, you have to go to the bank, they may question you. So you have to keep a copy of the act and tell them that yes, this is the act and we are bound to it. So we have to go according to it. So what basically can you expect at an inspection? So in an inspection, they are basically going to see whether you have all the equipment, all the manpower, and everything that is given in the act with you, right? So for a level 1 ART clinic, the mandatory staff requirement is a gynecologist itself, and initially they included a counselor also, but they have changed the rules, and now a gynecologist is sufficient. The minimum equipment required is a microscope, a centrifuge machine, and a refrigerator. Of course, all of us will have this if you are doing IUI. For a clinic, in the clinic you have to have a general waiting area, a reception area, a consultation room, an examination room, a store room, record room. It's the routine that we have. You need a clean area for IUI, performing your IUI and semen collection. You need a sterile area for autoclave and semen processing laboratory. So they're going to check and see if you have all of these in place in your clinic. They can also access all your records. They can see your case sheets. They can see your consent forms and see if you're doing everything in the right way. So the board can accept or reject the application. If they reject, they usually get back to you within a period of 30 days stating why they are rejecting it, and you can appeal. Okay, you can appeal for it. In case they accept it, this is the certificate of registration that they are going to give you, and this certificate of registration will be valid for a period of 5 years, after which you have to reapply. Now in case they reject your application, you will have to appeal, and you don't have to pay the fees again. So whatever you've paid initially, the same fees will hold good when at the time of your appeal, right? So the next thing is at what age group people can ART be offered. So when you want to go for any assisted reproductive technique, you have to make sure that the woman is between 21 to 50 years and the man is between 21 to 55 years. So even if one of them don't fall under this category, you cannot do an ART service. That is, you cannot do an IUI, you cannot do a IVF as well. So make sure that in your records, you have not done IUI for any person who is below 21 years. It's pretty common. I've seen this happening pretty commonly because they get married at the age of 14, they come to you, they say they are 5 years married and they want to go ahead for an ART procedure, but see to that it's not done because you will be answerable to the law. Coming to record keeping maintenance, so all the records that you have to be maintained for a period of 10 years, after which you have to submit the records to the National Registry. In case the clinic or bank is getting shut down before that, you can directly submit it there and then to the registry. And all the details of the procedures done, the diagnostics done, the tests done have to be submitted to the registry by the 5th of every month, and in similar lines to the PCPNDT that we had. So according to the Act, the record should be ideally computerized, and if whatever manual records you have should be kept in a fireproof cabinet. So this is the consent form for insemination for husband's sperm. This is the Form 7, which is mentioned in the Gazette in June, in the June Gazette. So you have to, this has to be duly filled in before you go ahead for the procedure. And the ART Act clearly states that you should be giving the couple a discharge summary or a report of their entire process at the end of the procedure. So coming to donor gametes, what are the considerations? So donor IUI, you have to obtain the sample from an ART bank, and it has to be a quarantine sample. Now what does that mean? The sample will be frozen, kept for a period of 6 months. The viral markers will be retested after 6 months, and only if it is negative you are allowed to use the sample. So this will prevent any infected samples getting inseminated if the sample was first seen at the window period. A bank shall not supply the sperm of a single donor to more than one commissioning couple. So this is very, very important. So you cannot, a person cannot donate his sperm more than once in his lifetime with the present ART Act. So it is one donor and one recipient commissioning couple, right? So previously also there was a restriction of 75 times and 25 times, but there was no, there is nothing to keep check of that, right? Because you don't know. He can just tell you that he has never donated before, but he would have already donated 100 times. But now with this present act, if you look into the consent form, please notice over here, you have to mention the Aadhaar card number of the donor who is donating the sample. You have to mention the ID number as provided by the ART bank, and you have to mention the registration number of the ART bank. So here it is like, the guidelines are strict enough that they have they've ensured that that person does not donate more than once, because it is Aadhaar card linked and it is going to enter into the national registry. If you enter the same Aadhaar card again, they will definitely find out that he has donated more than once. So it's pretty much, it's a welcoming thing, but the problem is we may not be able to have access to that many donor samples as we used to have before. So that is a point of concern, but maybe we should, maybe we, like how we have blood donation, we should start, telling our, educating our people more about this, and it's a welcome change because it is for the good. So coming to the penalties, so a number of offences have been described in the Act. So no baby can be abandoned after an ART procedures. Nobody can sell gametes or embryos. You cannot sell gametes or embryos for research purpose. You cannot exploit a commissioning couple. So all these offences have been mentioned in the Act, and the penalties have also been described. So for the first contravention, the first time you make an offence, you will be liable to pay a fine which is not less than 5 lakhs, which may extend up to 10 lakhs. The second time you make a mistake, you will be punishable for an imprisonment, which is a term not less than 3 years, which may extend up to 8 years, or a fine which is between 10 lakh to 20 lakhs. So all these offences are cognizable and bailable, and it also states that all the whoever contravenes any provisions of the Act for which the fine is not mentioned also will be liable to the same punishment. So sex selective assisted reproductive technique is a bigger offence, and for this you could be punishable with imprisonment for 5 years, which may extend up to 10 years, or a fine from 10 lakhs to up to 25 lakhs, or sometimes even both. So finally we see some light at the end of the tunnel. So I don't want to scare all of you because see, IUI is a basic procedure which definitely gynecologists should perform, otherwise there will be a huge gap in the fertility management. So this is the portal wherein you will be accessible to all the forms, application forms, all the consent forms. So this is how it looks, right? So from here you can download all of this and you have to duly fill in. So as long as we are in practice, definitely we'll come through several challenges, but we know how to go through these challenges. So know the law, do according to it, and you can practice with confidence like a boss. Thank you so much.
Thank you, Dr. Suma, for the ART, donational ART rules, awareness, because we being medical people, we won't bother about this administration rules and everything. We will bother about scientific, the scientific session only, how we are doing in the cases, how we are attending, and is there any complication. So similarly, our minds will go, and our minds will not go according to the GO. Now this national ART rules came. So it is a good thing you covered this subject today, because giving awareness for all IUI clinics also. IVF clinics compulsorily they will register, but IUI clinics, many clinics may not register. So it's nice to cover all these things today, and thank you once again.
Thank you, ma'am. Thank you.
Thank you, Suma. You have done well. Regarding registration,
yes, ma'am.
If there is any OPD clinics registration,
Yes,
it has to be registered in the clinic, or if they go and do the procedure in any hospital, that has to be registered, and the consultant also to be registered. Because
okay,
one
I understood, ma'am. Some doctors tend to do the protocol and they obtain the sample from a different clinic. If you are doing the insemination in your clinic has to be registered.
Okay.
So if according to the ART Act, if you want to transfer gametes from one center to the other center, it can be done, but with permission from the national board.
Okay.
So it requires some paperwork. So whoever is supplying the gametes should be registered. Whoever is taking the gametes also should be registered. So when you are registered, why don't you do it yourself now?
No. What I am asking is, suppose consultant is going and doing the procedure in some other hospital.
Yes,
that
has to be
hospital
registered.
is registered.
Even the consultant should be
That
registered.
consultant has to.
Yeah. Yes, ma'am.
How
Because
much is the fees for the
50,000
consultant?
for level
So
1.
for
For only
consultant-
IUI, it's 50.
Okay. For consultant.
Also.
For hospital?
For both, ma'am. See, if you want to go and do there, you also have to register.
Okay.
But the thing is, they won't grant you a registration if you don't show that clinic. You have to be attached to some clinic. Or maybe you should apply for it and you should show the clinic you are getting attached to.
Okay.
See, because it's not only about the manpower, it is about the equipment, it is about those areas, it's about everything that they're seeing. So, if you go and do it, maybe it will not be under you unless you register.
Excuse me, Suma. If the madam name was registered in that clinic, that is enough, I think.
Yeah, that's what. So in the manpower of that particular clinic, apart from the main consultant, maybe they should have your name also.
Okay.
But you should, when they come for an inspection, you should be there to show them your certificates also.
Okay.
That's what, they look at your registration certificate, your basic degree certificate. So if supposing you want to do it with, say, Ashalata madam, in Ashalata madam's application, apart from Dr. Ashalata, Dr. Bharati has to be included.
Okay.
Then it will hold good. Yes, ma'am. Through the clinic, yes, ma'am. Yes, ma'am. Yeah.
No, now you are
Thank you,
telling
Suma.
differently.
We are running
Okay.
out of time, madam. We will proceed with the next panel discussion. Before that, I will let you.
Whoever is having the name boards with the name of Santana Safalya Kendram or everything, they have to get registered under DMHO, because they have given very strict orders. Otherwise, you have to change the name, because they are seeing the name boards and they are coming and they are giving the notices to all the hospitals. From the DMHO, we are getting notices. And one more thing, what Suma said, like madam is asking, if the center is getting registered under this ART bill, from the center only doctor has to get registered. Unnecessary, there is no other any registration for the doctor separately. If you are going for registration of IUI clinic, you have to mention the gynecologist. How many gynecologists are there in the center? Who is the andrologist also? So anybody can register under that IUI clinic. They can go and do that IUIs in that premises. But one thing I wanted to share you, everyone has to get registered. Whoever is having the name board as Santana Safalya Kendram. These are the strict instructions given by all the DMHOs, district DMHOs. And anytime they can come for the surprise visit and they can charge you huge of amount. And one more thing, Suma said like Aadhaar card is very, very important to take the oocyte donor or sperm donor or anybody. But I want to tell you if, in one or 2 minutes, like because Aadhaar card also patients are coming with fake Aadhaar cards. They are manipulating the Aadhaar cards and they are coming. Recently the incident has happened in the Tamil Nadu. One minor girl has given oocyte donation for 8 times. She has given the Aadhaar card of 22-year-old, like patient name is Banu, but our original name is different. And the issue is going in the different way in the Tamil Nadu government, and the government has shut down all the 3 hospitals where she has given the oocyte donation. So as a practitioners, we should be very, very careful while taking the oocyte donors especially, because we don't know whether the girl was looking like more than 25 years, but she is 10th class, she has written recently it seems. So Aadhaar card also, we can't trust the Aadhaar card. We have to do our safety measurements while taking the oocyte donor or sperm donor also.
Thank you, madam.
Thank you.
Thank you very much. I request the chairpersons to present memento to the speaker. I will like to request Dr. Bharati madam to present mementos to our chairpersons, ma'am. I would like to request Sunita Subramaniam madam also to present the mementos to the chairpersons. We are now moving on to the next session. The next session is the panel discussion. The topic is recent advances in the diagnosis and the management of gynecological malignancies. And our moderator is Dr. D. Jayakumar sir, and sir is Associate Professor from the Department of Surgical Oncology from All India Institute of Medical Science, Jodhpur. Sir, we welcome you, sir, onto the dais. Then our panelists, and the first panelist, Dr. T. Bharati, and madam is a well-known face and a true inspiration to all of us. Thank you, ma'am. Next, I will like to invite Dr. S. Surya Sen, and sir is a senior surgical oncologist and laparoscopic surgeon. And next is Dr. P. Nageshwar Reddy, sir. Sir is a medical oncologist at Sri Venkateswara Institute of Cancer Care and Advanced Research. And our next panelist is Dr. Karthik STS, and sir is a surgical oncology consultant at Sri Venkateswara Institute of Cancer Care and Advanced Research.
Good afternoon. At the outset, I thank the organizers for giving me this opportunity to moderate this session. Slides are already given, sorry.
Yeah, that it is raised this point.
Ovarian cancers. Then when comes to the uterus, you have the endometrial cancers and the sarcomas of the uterus. Then carcinoma of vulva. The ovarian mass, ovarian cancer may be secondary deposits from other primaries, and or it could be a primary arising from the ovary. You have the common three types: epithelial ovarian cancer, germ cell tumors, and sex cord tumors. Out of that, epithelial ovarian tumor is the common one. We are going to present few cases and discuss about the management. Yes, this patient, 38 years old, premenopausal woman, presented with an abdominal distension of 4 months duration. She is married, had 2 children, completed the family. There is no family history of cancer in this. And general examination, nothing much contributory, especially no lymph nodes anywhere else in the body, and no symptoms suggestive of distant metastasis. We have done an ultrasonogram of the abdomen. There was an adnexal mass of 30 into 20 centimeters and minimal ascites, and the tumor markers were done, they were all normal. So what could be the next investigation for this patient, sir? Suryasan, sir.
Sir, the clinical examination is over, tumor markers are done.
Normal.
Okay. Now ultrasound transvaginal.
X-ray chest is also done.
X-ray chest is done.
Normal.
Ultrasound abdomen and if possible
Pelvis.
intravaginal, transvaginal ultrasound abdomen. Ultrasound also is useful.
Yes, sir.
And in cases where there is a suggestion of malignant suspicion on ultrasound, you may have to go for MRI pelvis. MRI pelvis is one thing we would like to utilize.
Yes, sir. Okay, this is a large cyst occupying, this is a heterodense lesion, cystic and solid components, and the abdomen and pelvis, we would like to know about the solid components, and then ascites is there or not. There is no ascites, there is no para-aortic nodes, and of course liver is also normal. Para-aortic, pelvic lymph nodes are not enlarged, and already our X-ray chest is normal. Now how to proceed further, sir? A complex cyst of 30 into 20 centimeters size.
As per the current clinical scenario, the patient is having an adnexal mass, which is most likely to be a complex ovarian cyst.
Yes, sir.
With all the markers normal,
Yes.
and size of the cyst was around 13 into 20 centimeters.
Yes.
With minimal ascites.
Yes, no, almost no ascites.
Almost no
Ascites is not
ascites.
there.
So in this case, we'll do a staging laparotomy for her.
Yes, sir.
So we have to open the abdomen by a midline vertical
Yes,
incision.
yes, sir. Yes, sir.
And then initially you have to check for presence of ascites.
Yes, sir.
And you have to go in the clockwise direction, checking in the paracolic gutters whether any metastasis is there. And then you have to palpate the liver and see whether any surface
Yes,
deposits
yes,
are there
yes.
or not. And then you have to check for the falciform ligaments and the spleen also, like in the counterclockwise
Yes,
direction.
yes, yes.
So once you are sure of non-metastatic disease, then you have to perform a simple hysterectomy for her along with the removal of the adnexal mass in toto, preferably not to rupture it during surgery. And THBSO is what we can simply call it as. And if you have the facility of frozen section available, you have to send that adnexal mass for frozen analysis. And if it turns out to be malignant,
Frozen comes out as negative, we will close the abdomen.
no, but still we will do a pelvic lymph node dissection. So in order to stage bilateral pelvic lymph nodes, we should address.
Yes.
And we have to take random peritoneal biopsies also.
Yes, sir. Yes,
from the paracolic gutters and all.
Okay. Here, what is the other photograph is not there. We open the abdomen in the midline. We remove the cyst. When there is a large cyst, you cannot do whole THBSO. So first you remove the cyst without rupturing it, and then if before removing the tumor, if there are ascites, you can aspirate it, and then put in the we add heparin to prevent coagulation, and then you remove the large tumor, and then take a peritoneal lavage, wash the subdiaphragmatic paracolic gutter, small intestine, and the pouch of Douglas around 200 ml. So it is sent to the pathology department for centrifuging and studying for the malignant cells. And the uterus, which is the largest peritoneal surface, or the sites for recurrences, we do hysterectomy also. The opposite ovary also is removed. Here important thing is that the woman has completed the family. Otherwise, we have to retain the uterus and the ovaries. So, if the ovary is unilateral ovarian tumor, there is no problem. If there are bilateral tumors, then we may have to preserve, or we have to get a consent for everything. So, that is there. Then we do what is called a staging laparotomy is done when a early stage malignancy. We do what is called a infracolic omentectomy. Below the colon, we remove that, and these are all the pelvic nodes that is there on either side. There are 4 peritoneal node biopsies. Yes, sir. Now, see, there is such a long incision we have made. This is another patient which was planned for a benign tumor, and then we excised like that. Okay. Now, for this patient, the histopathology comes out as a malignant epithelial ovarian tumor, grade 3. The surface is free of tumor. The peritoneal fluid is free of tumor. The pelvic nodes are pelvic node and omentum, there are no deposits. So, what we will do, any adjuvant treatment patient requires.
Yes, sir. I understood from the way you described, it is grade 3,
yes,
stage 1A. There is
stage
no breach
1.
of the tumor,
Yes, sir.
there
Yes,
is
correct.
no tumor over the surface, and even the ascites and peritoneal washings are not showing any malignant cells. So, this histology, usually histology is one thing which we should look
Clear
at.
cell, clear cell.
Clear cell. Clear cell histology, irrespective of anything, should be offered adjuvant chemotherapy to
Yes,
reduce
sir.
the chances of recurrence.
Okay.
And suppose the most common histology is high-grade serous carcinoma. In high-grade serous carcinoma, the factors that decide on adjuvant chemotherapy in early ovarian cancer, say stage 1 and stage 2, are grade 3. This is grade 3.
Yes,
so,
sir.
if any grade 3 cancer, irrespective of stage, should be offered adjuvant chemotherapy.
Yes.
And the stages where we can avoid adjuvant chemotherapy are stage 1A or 1B with grade 1.
Yes.
Okay, only this subset of patients can be avoided of chemotherapy. Rest all the patients, especially from stage 1C onwards, should be offered adjuvant chemotherapy in order to decrease the chance of recurrence and to prolong the recurrence-free interval. Thank you.
1A, 1B. Now, the 1C is peritoneal fluids positive. So if you rupture the tumor, then it becomes a 1C. What is that 1A will become 1C. So in certain cancers, 1A we may not, we need not give chemotherapy.
Yes.
What are the regimes, sir, you give?
Sir, to answer the question, sir, even 1C, there is division into 1C1, 2,
That
3.
is there.
Because if it is ruptured by itself, that indicates the poor biology of the disease.
Yes.
If it is only a surgical
No,
spill.
that is there. Rupture, poor by natural rupture, okay. During removal, I am telling.
That is why it is staged before
Okay.
natural rupture, sir.
Yes.
Yeah. And regarding the chemotherapy regimen,
Yes.
sir, usually a doublet chemotherapy regimen should be used. One from the platinum and the other from taxane. So the commonly used regimen is paclitaxel and carboplatin. So combinations of docetaxel, paclitaxel plus cisplatin and carboplatin can be used. But the problem is docetaxel has a bit of higher hematological toxicity, and cisplatin has high risk for neuropathy and also ototoxicity along with nephrotoxicity. So the best combination would be paclitaxel plus carboplatin given every 3 weekly for over 6 cycles.
6 cycles. So this is the adjuvant treatment is over. The patient will be on kept on.
At one point, I'd just like to say that if the surgical spill happens, the 1A disease becomes 1C1. So that's why it's better always do a vertical midline incision rather than a
that is
transverse and then trying to extract the tumor.
And transfer will be difficult to deliver also. This
Exactly.
you can't extend. And the vertical incision is easier to do than the transverse incision. In 80s, when we were all PGs, the issue was there was no synthetic or non-absorbable suture material. The abdomen will be closed with the catgut. 10% of the abdomen will be burst abdomen. Now that problem is not at all there. There is a wonderful loop ethylon. So you can easily go, you can easily remove it, close it also. Thank you, sir.
Sir, with your permission, one more thing. So the question that sometimes an adnexal mass is there, it is removed by gynecologists, and
Yes,
then it is reported as a very early stage disease, probably 1A, stage 1A, grade 1. But here the question is, it is not properly staged, so we cannot abstain chemotherapy for that.
What is your advice, sir?
See, you have to take that. This patient, what Dr. Nageswati said, no chemotherapy, applies only when it is properly staged. If it is not properly staged, and if it is a simple adnexal excision reported pathologically like that, then we have to take it with a pinch of salt and go ahead with giving either chemotherapy or go ahead with staging laparoscopy.
Here,
exactly, sir, totally agreed.
I tell you one thing, that what we do here is a peritoneal toileting and then removing all these things. When they remove it and then it is reported, if we have to again evaluate it and then we can complete the staging. But we do not know what was the peritoneal disease or not. So that is one issue that we commonly come across, because I used to tell them every time somebody presses the calling bell, you have to cautiously open. You cannot open just like that. A family member is coming, a thief may come, and patient will be running here and there. Okay, right. Now I follow up. I will finish follow up. Every cancer patient are to be followed up for the following: one, a recurrence of the disease, this disease, or a second primary malignancy, or for complications of the treatment. Here the complication of the treatment is incisional hernia. So patient every first 2 years, 3 months, you see, you do a general examination, pelvic examination, basic ultrasound, X-ray, if that, and tumor markers, or the follow-up. Okay. Okay, this patient is a 48 years old postmenopausal woman presented with the bilateral adnexal mass, ascites, pleural effusion, pelvic deposits, CA120 was raised. The patient after metastatic evaluation POD deposit was aspirated. That was the malignant cells positive for malignancy. The patient received neoadjuvant chemotherapy. Patient, totally the pleural effusion disappeared. Then the ascites also disappeared. There was a residual tumor in the ovary, both sides. So how to proceed now, sir?
So 4 cycles of chemotherapies are over.
Yes, sir. Yes, sir.
So now we have to go ahead with the classical cytoreduction, as already Dr. Karthik also has elaborated. A vertical midline incision is always preferable. Go with a TAH with BSO plus omentectomy and all the peritoneal biopsies. But these peritoneal biopsies are of less useful now.
Yes, sir.
At this time, because already it is staged higher up. So removing optimal cytoreduction is the idea. So
Yes, sir. Optimal cytoreduction means tumors less than 1 centimeter should be there, so that the subsequent chemotherapy will take up one. In this case, we have done a CT abdomen and pelvis. There are tumors. The surface of the peritoneal surface could not be evaluated by the CT scan. There may be small nodules over the small bowel and other things where you cannot operate. So we put a laparoscopy. Laparoscopic, see, this is the diaphragm, chest wall, liver you could see totally free of nodules. So this is the ligamentum teres. Rest other than the pelvis, there was no tumor anywhere. Small bowel was there, mesentery was free. Then pelvis, everything is stuck there. We cannot move anything. So we opened up the patient in the midline. So this is the tumor. There is a cystic lesion, bilateral cystic lesion. We have done the panhysterectomy, bilateral salpingoophorectomy, and then we looked for any para-aortic pelvic nodes. There was not enlarged. If they are enlarged, it has to be cytoreduction has to be done. So that is the interval cytoreduction. And the postoperative histopathology is tumor positive in the ovaries, bilateral ovaries. Now,
Sir, along with that, the pathologist also will comment on the extent of response. If there is a good response to the...
the response are 3. Complete response, partial response, stable disease or progressive disease. Here there is a partial response.
Sir, if it is partial response, then we'll continue adjuvant therapy to a total of 6 to 8 cycles.
Yes, what drug you are giving, sir?
We'll continue the same drug which was given in the neoadjuvant chemotherapy.
Cisplatin sensitive tumor and resistant tumor.
Yes, sir.
Yes, sir. Thank you, sir.
And
any role of radiotherapy in ovarian cancer?
In the current era, there is no role of radiation therapy, sir. But noteworthy point is before the invention of modern cytotoxic agents, there used to be something like whole abdominal irradiation, wherein the whole of the abdomen used to be irradiated for palliative purposes. It couldn't cure the disease, but then it was given for palliation.
That is called WAR. Whole abdomen radiation.
Radiation.
Another one, radioactive phosphorus was also used intraperitoneally. That and all, I don't think no one is...
Radioactive phosphorus is having too much of hematological toxicity.
Yes, yes. Again, the intraperitoneal chemotherapy, hyperthermic intraperitoneal chemotherapy, do you...
Yes, sir. This regional chemotherapy is of 3 types, sir. Like IV, IP, intravenous plus intraperitoneal chemotherapy is one thing. Next thing is HIPEC, hyperthermic intraperitoneal chemotherapy. The third thing is PIPEC, pressurized intraperitoneal chemotherapy. There is good evidence for intraperitoneal chemotherapy, and the indication for that is not stage 1, stage 2, stage 3, stage 4, who were eligible for optimal cytoreduction. Here the optimal cytoreduction is defined as residual disease to less than 1 centimeters. So all those patients who underwent upfront cytoreduction, that is optimal cytoreduction with a residual lesion of less than 1 centimeters, are candidates for intraperitoneal chemotherapy. But the problem here is only 42% of the patients could complete the whole planned intraperitoneal chemotherapies. It is toxic. So one other option is to give intravenous chemotherapy and also dose dense. Dose dense is instead of giving 3 weekly regimen, we need to give every weekly, splitting the 3 weekly doses into 3, and then total of around 18 weeks should be given.
Now, here, if there are deposits in certain places, we can remove that also. For example, there is a spleen deposits are there, you can remove the spleen. Even if in large bowel, single segment, smaller segment is involved, we can remove. That is there. Here there is no pelvic disease, the bladder, everything is free. Okay. This is an emergency. So, adnexal mass they can present also as an emergency, pain, and in an emergency, staging laparotomy full extent may not be able to do. You may not have the expertise or you may not have the anesthetic infrastructure and all these things. So you remove this patient. We did this patient is an 18 years old girl presented with the pain right leg fossa. Actually an appendicular pathology was suspected. Scan showed this torsion ovary. We opened up and then we do not know whether it is a benign or malignant. So we did a fertility preserving staging laparotomy. We fertility preserving, what the normal ovary was left, the uterus was left. Rest of the things we did, and fortunately patient's histopathology came out as a mature dermite. So you want to give anything for this mature dermite, sir? Medical oncology.
For mature teratoma or dermatitis, there's no role of
we push on whenever we have no push on. Don't bear all the responsibilities. Share with the medical oncologist.
Sir, and here the most important is part comes for the pathologist, sir. There should be meticulous grossing of the tumor, if at all, if there is any immature component, or sometimes the differentiated parts of dermatitis can develop a secondary adenocarcinoma. So, for example, thyroid adenocarcinoma can be developed here. So those should be meticulously identified. So pathologist has a good role in this kind of tumors.
Okay. Now
one more thing, sir, about the surgery. For a young lady, adnexal mass with a torsion, probably preoperative diagnosis will be there with the torsion, usually. And if the tumor markers are negative, and we can go for a laparoscopic surgery for this patient, provided you use a retrieval bag. If we don't use a retrieval bag, there is a possibility to spill the thing and all. If we use a retrieval bag, we can prevent the spillage and we can deliver the specimen. So in that way, laparoscopic can be offered for this patient.
Actually, if we can deliver through the laparoscopy, when we go, many times the specimen is delivered through the vagina. Commonly laparoscope is done for endometrium and also cervix. So that is there. Here we have not done a hysterectomy also. So you have to deliver it through the abdominal wound only.
Yes, sir.
So maybe 8 to 10 centimeter we have to, or we have to marsupialize inside.
Yes, sir. That's what we do. We deliver the opening of the retrieval bag outside. Then the bag with its contents are in the abdomen.
Yes.
Then we will morcellate it and remove it.
These
So it only requires 2 to 3 centimeters, 3.5 centimeters. But the only thing is, if the patient is having a benign one, unnecessarily doing a laparotomy, that we can avoid.
We do not know whether it is a benign or not. And I tell you, for nearly some 30 years, we have seen some 7 or 8 cases only. So what is it? If it is common, then okay. It is very rare. Once in a thing, we will go for a conventional surgery. That is there. Okay. What is the screening? That is what we have to do. So, Madam.
Usually the ovarian cancer will be without, that means asymptomatic. But in early stages like stage 1 and stage 2, though they get some symptoms like indigestion, bloating abdomen and constipation like that, we think that it's a non-specific and we do give only symptomatic treatment.
That is.
So that's why usually the ovarian cancer we expect after 50 years like that. If there is any suspicion, we do CA-125 and
Yes.
TVS. But those who have family history, like breast cancer in their family, any ovarian or breast cancer like that, for them we can do screening like a TVS and CA-125 from 35 years onwards, so that early we can detect. And if there is any high risk like BRCA1 and 2 genetic
A family history
exposure
of
is there,
cancer is there.
then we can do risk reduction oophorectomy also. Otherwise,
The BRCA1 and 2 are the tumor suppressor genes. Their protein activates that P53 tumor suppressor gene, and they are more prone for you. You will be knowing Angelina Jolie. She has underwent bilateral mastectomy and bilateral oophorectomy. So this juice, they are more prone for that. Even we have seen also, I have seen a patient, a 30 years old woman coming to the hospital. My grandma and ma had are BRCA positive. Then what to do now? Now no disease. Then I asked her, what is your age? 32. Got married? No. Why? Not suitable bridegroom. No, get somebody, become pregnant, complete, come to me, I will remove both. Like that. Now, it is not 100% also ready, it's not risk avoiding, it is a risk reducing 90%. Because the peritoneum also, the fallopian tubum also have the same epithelium that can turn into malignancy. So that is there. Okay, this is the third one, carcinoma endometrium. She is 60 years old. She presents with a bleeding PV, post-menopausal bleeding PV. USG of general examination, there are no distant sites of metastasis. Past history, she had a locally advanced breast cancer 20 years back in the right breast. She underwent modified radical mastectomy. I think some more breast issues are there. Modified radical mastectomy, first neoadjuvant chemotherapy, MRM chemotherapy, radiation, and on tamoxifen. So 5 years of tamoxifen was over. Tamoxifen is one of the patients who are taking tamoxifen are high risk, like obesity, hypertension. The endometrial cancer is an elderly cancer occurring one. The prone factors are obesity, hypertension, then low children, infertility, all these groups they come. So we evaluated the breast also now, both clinical examination of the right breast and mammography of the left breast normal. Okay, then fractional curettage, ultrasound was done, CT also was done because the patient was having a big bulky uterus. Okay, this was the uterus. So fractional curettage was done, reported as an adenocarcinoma. She underwent type 1 hysterectomy. This is what we call it as a surgical staging. We do hysterectomy. There are 5 types of hysterectomy. The hysterectomy types are based on where we ligate the uterine artery, where we ligate the parametrium, and how much the vagina is taken out. So here, when we do a type 1 hysterectomy, we ligate the uterine artery at the uterus, and the vagina only 3 to 4 millimeters. So it gives a margin. So this is a type 1 hysterectomy and bilateral pelvic lymph node dissection done. So here there was no metastasis radiologically and also perioperatively. Now, histopathology adenocarcinoma grade 2 infiltrating more than half of the myometrium. So now what to do further? Any adjuvant treatment we have?
Sir, would like to know more information in the pathology report. Now, definitely it is stage 1B because the infiltration is more than one half of the myometrium. The exact histology, grade, lymphostromal vascular invasion, involvement of parametrium, involvement of lymph nodes, all these things are important, and based on these things we divide the patients into three categories, three risk group categories based on the risk of recurrence, chances of recurrence: low risk, intermediate risk, and high risk. Low risk patients are those with non-high risk histologies. Like high risk histologies meaning serous carcinoma, clear cell carcinoma, carcinosarcoma, all this comes under high risk categories. So non-high risk histologies, grade 1 or grade 2 endometrioid carcinoma, those with invasion less than 50% of the myometrium, all this comes under low risk group, sir. And for the low risk group, there is no adjuvant treatment. They can be observed. And in the intermediate intermediate risk group, here those with grade 1 and grade 2 endometrial carcinoma, but with more than 50% of myometrial invasion, and also grade 1, grade 2 endometrial carcinoma with lymphovascular stromal invasion. These two along with stage 2 patients. Stage 2 endometrium means involvement of the cervical stroma. These three group of patients need some kind of adjuvant chemotherapy. According to
adjuvant chemo or radiation?
Adjuvant radiation therapy. According to few trials, even these intermediate patients are categorized into low intermediate and high intermediate, depending on the three factors like age criteria, LVSI, grade 1, grade 2 endometrioid carcinoma, and then myometrial invasion. So for low intermediate, patients can be observed. In high intermediate, radiation therapy is indicated, and even in this high intermediate there is no need of external beam radiation therapy, which puts the patient at high risk for late and early toxicities from radiation therapy. Vaginal brachytherapy would suffice for high risk high intermediate risk patients. And then comes the high risk category, which includes patients with high risk histology. So high risk histology in the sense clear cell, serous, and then carcinosarcoma, and all those patients with stage 3 and stage 4 also. From stage 3 onwards, there is no good role of radiation therapy. Chemotherapy with or without vaginal brachytherapy would result in improved survival and decreased local recurrence. So it's more important that pathologists should do a good job for us to give the appropriate treatment.
Before, with your permission, sir, before going to the adjuvant treatment, because we are talking to the group of gynecologists, type 1 hysterectomy we have suggested now for this patient. So there is a subsegment of patients in whom a preoperative MRI or CT has shown a cervix involvement by a CA endometrium. Then it is better we go and do a formal radical hysterectomy, just like what we do our CS cervix. A CA endometrium involving CS cervix has to be treated like CS cervix. Do a typical type 3 radical hysterectomy with the bilateral pelvic lymphadenectomy and then stage it. That would be the thing. Yes. So in this patient, in this way, an MRI or a CT can help us in knowing whether the lower part of the uterus is involved.
Uterine malignant, endometrial carcinoma, you need an MRI to know about the local extent of the disease. They will even say how much myometrium is involved, then the nodal status, then the liver metastasis, all these things.
One more point, sir. If the histology is clear cell or serous, papillary serous in endometrium, it should be treated like an ovary, like how is Saris saying that if it involves cervix, it should be treated like a cervix. If the histopathology is a non-endometrioid histology, like if it is clear cell or serous, then we have to do pneumontectomy also, along with the entire staging.
Yes. Good. Thank you. So this is the surgical staging. It may require a type 1 or type 3 hysterectomy. Then adjuvant radiation is the treatment for early cancers. Advanced metastatic cancers, you may have a palliative treatment. I think medical oncologist Nageswara Rao.
Yes, sir. So palliative treatment, even then, even if it is upfront stage 4 disease, I would like to ask my surgical colleague if at all if surgical cytoreduction is possible. If at all if it is possible, and then if the patient is suitable for surgery, I'd be happy to give chemotherapy post surgery.
Yes.
So that will improve the chances of survival, and also it gives a good quality of life to the patient.
Quality of life.
And then radiation, except for in endometrial cancers, except for hemostatic artery and symptomatic artery to the bony metastasis, there is no good role. Yeah, there is no good role of radiation therapy other than for palliation. And then systemic therapy. Under systemic therapy comes chemotherapy and hormone therapy. Chemotherapy I have described just now, and the same paclitaxel and carboplatin, which is standard for ovary, also holds good for endometrium. But the endometrium is not that responsive comparatively. And next comes the hormone therapy. For adjuvant therapy, in adjuvant setting, there is no role of hormone therapy.
Yes.
And just to give what kind of hormone therapy we use, basically endometrial cancer, if you look at the pathophysiology, it is mostly driven by the estrogen. Because of unopposed estrogen action, patients will develop endometrial cancer. So here we need to give progesterone therapy, like either medroxyprogesterone or megestrol acetate. We usually prefer megestrol acetate. And hormone therapy role also comes in fertility preservation. For eligible group of patients with grade 1 endometrioid carcinoma and the disease being confined only to the endometrium without any myometrial invasion, and if the patient is wishing for fertility, those can be tried. I mean, hormone therapy can be tried for fertility preservation, and there is a protocol for that, like IUD with levonorgestrel along with megestrol acetate 80 mg, and then continuously for 3 months, then repeat endometrial biopsy after 3 months. If it is responding, then a second biopsy needs to be done after 3 months. So if 2 consecutive biopsies did not show anything, then patient is advised to conceive as early as possible. And then other role of hormone therapy is in the even in the first line setting for a metastatic endometrial cancer, there is no standard guidelines that we should use hormone therapy, even in the second line also. So, but for the patients who cannot tolerate chemotherapy, it can be tried. And one another setting where hormone therapy can be tried is metastatic low-grade endometrioid stromal sarcoma, endometrial stromal sarcoma. This endometrial stromal sarcoma, especially low-grade, like they express hormonal receptors in almost every patient. So it can be tried in low-grade endometrial stromal sarcoma.
Yes.
Then chemotherapy we discuss.
This is one patient. She presented with the endometrial carcinoma, huge tumor with a large parietic node. This patient was treated by medical oncologist. The tumor has regressed and the node has become very, very small. So we did a type 1 hysterectomy, pelvic lymphadenectomy, and this is RPLND, retroperitoneal lymphadenectomy. The patient had a residual disease in the uterus, nothing in the nodes. So here comes, are you going to do a screening? Madam?
Usually we don't do routine screening for endometrial cancer, sir.
Yes.
Because usually it will be in advanced stage, and those who are at high risk and low fertility, for those people we will do. And those who have family history like Lynch syndrome or hereditary colon cancer or associated breast cancer and small bowel cancer, like that, for those people after 35 or 40 years we can do annual fractional curettage, it is described, but we have not done any annual DNC like that. But we do
DNC
explain
is not simple.
fractional
perforation, bowel coming down, all these things are there.
So we do explain them, and we can do.
We can, I think,
risk reduction.
completed family take out the uterus. What is there? That is simpler than doing every time you do every year fractional
No,
uretage.
we don't do. It is described in book, but we don't do like that.
I was telling why they didn't recommend that. Okay, what is Lynch syndrome?
So Lynch syndrome is.
Lynch basically is a DNA mismatch repair genes
Yes,
defect
sir,
will be
yes,
there.
sir, yes, sir.
So we have all the 5 genes which are described there. There is almost more than 50% chance of developing endometrial cancer as well as colon cancer also. So in these cases, generally if a family is diagnosed as Lynch syndrome, if an index case is there, then in the follow-up patients also, 5 years before the cancer develops, we should start doing colonoscopy. And as soon as the patient completes family, if she is a female patient, we have to go for a hysterectomy, sir, in a Lynch syndrome.
Yes, there are surgeries done for the prevention of cancer. First is undescended testis. That has crossed more than 6 months. There is a guideline, bilateral, unilateral. Okay, that gives. The second is the polyposis coli, hereditary polyposis. This is non-polyposis coli. You know, hereditary polyposis coli, they develop by 3500%. They develop malignancy after 15 years. So, how to diagnose? You don't need to any genetic testing. Put the sigmoidoscope, hundreds of polyposis, that's all diagnosis. Now here is the non-polyposis coli. The patient will not have the polyps normally. You have to screen. Normal colon screening is at the age of normal, every patient, average risk and high risk. The average risk recommendation, American Cancer Society is 50 years, whereas this is at a earlier age, somewhere around 30. You do that and then have a follow-up. We will finish it, madam. This is carcinoma cervix. So what is that? Intermenstrual bleeding. All these symptoms. Examination we know. Investigations. So general examination, local examination. Use the abdomen pelvis, because to know about hydronephrosis, non-functioning kidney, then MRI of the abdomen. Then sometimes you may require a cystoscopy and anterior fornix is involved or symptomatic. Then posterior fornix or rectum is suspected. Then disease exophytic, you go for a punch biopsy. You suspect an endocervical lesion, go for a fractional curettage. Now, cancer, I will first confirm the cancer. Then I will stage it. Then I will treat according to this stage. That is the 3 principle. Sometimes we don't confirm the cancer, ovary, we don't do a biopsy. Okay, here, okay. Early stage means 1B1. Up to this is 1B1 is 4 centimeter. Fornices are free. Some books say smaller 2A. Fornices are involved. That's all. Now you will do virgin cystectomy. What are the structures will be removed?
Vertins generally comes in type 2 hysterectomy or modified radical. Generally we will go for a type 3 hysterectomy. So for CA cervix, 3 things which we should remember is where we are going to ligate the uterine artery.
Yes.
So in type 3 or Vertins, we will ligate the uterine artery near the origin from the internal iliac. So from there you have to resect the parametrium. So even one more thing we should take into consideration is how you are dealing with the ureter. So
yes.
Ureter. So radical hysterectomy is nothing but lateralization of the ureter and remove everything which is in between.
Yes, yes. That's all the principle.
Yes.
We remove the vagina also some 3 to 4 centimeters, 2 to 3 centimeters. Okay. Patient not willing for surgery, unfit for surgery, radiation. If the patient is asking you what surgery or radiation, what you will suggest?
I'll prefer a surgery, sir, if it is an operable disease. But in India, getting such cases is very difficult.
One thing, this option comes in various places. Surgery versus radiation. You do a surgery, then the specimen is completely removed. You have the margin status, whole histopathology, all these things. In radiation, it is not so. Number one, the surgery can be repeated. For example, lip is there, you remove this, again recur, remove. But radiation, a full dose is given. Generally, you cannot repeat it for another 5 years. Number two, then there are then the duration of the radiation, all these things are there. Here, if the pelvic radiation also, so many complications can be there. So, if the patient is willing for surgery, otherwise no surgery. Now, advanced disease. Sir, Nageswara Rao, sir.
Sir, just to discuss the previous point you have told, sir, radiation therapy can also be given, sir, because post-surgery, if the features is not good,
Yes,
the patient
adjuvant
may need
radiation may be
adjuvant
required
radiation
in
therapy.
early also.
The problem is, sir, adjuvant radiation therapy will result in more of acute and late toxicities, because
That is
whatever the structures are removed, the space will be filled by small bowel. So, lot of enterocolitis will be there. So, for advanced disease, the standard treatment would be concurrent chemoradiation, where we give external beam radiation therapy to the dose of 50 gray to the whole of uterus, cervix, 2 to 3 centimeters below the lower vaginal involvement, obturator, iliacs, up to common iliacs. If there is a lymph nodal involvement, we go one level above the
Yes,
that
sir.
particular involved level.
Yes, sir. Yes, sir.
And then along with weekly chemotherapy, usually cisplatin, that is the standard 40 milligrams per meter square. So once the concurrent chemoradiation is completed, then we go ahead with brachytherapy. So brachytherapy is part and parcel of cervical cancer treatment, and any form of conformal radiation is ineffective and inferior to the brachytherapy. So brachytherapy should be part of cervical cancer management, especially if surgery is not being done.
Sir, one thing I wanted to tell you, virgin cystectomy and other for cervix and endometrium, we do the laparoscopy, and now that the robotic has come now. Okay. Now, sir, what are the advanced management of residual recurrent disease? Serious, sir. Yesterday.
You were asking me about the primary disease.
No, sir. We have given central recurrence, posterior part is involved, anterior part is involved, post-chemo radiation.
Then the post-chemo exentration, sir. We have to go for
Yes,
exentration.
sir.
So if the central disease is only there and parametrium involvement and the pelvic side wall involvement is not there, then only it will be useful. Otherwise, doing an exentration and again the patient fails in the pelvis as well as elsewhere will not be useful.
There are 3 excentrations. You remove the uterus and the bladder, that is anterior exentration. Remove the uterus and the rectum is I tell you, we are biting the lunchtime now. That is why I am going slow. Okay. One is that where we were pelvic excentation, anterior excentation. Remove the bladder, keep a ileal conduit, urine comes there. Posterior excentation, remove the rectum and uterus, keep a colostomy. Both remove everything, keep a colostomy, ileal conduit, and you can put same one together. That is called a wet colostomy. Okay. Yes. This is one of the patient who had a 3B cancer, had an intestinal obstruction, residual disease. We have done a diversion colostomy. Okay, cancer cervix screening. We do not know anything, so I put the blank to madam.
Sir, the cancer cervix is the one thing which we can try to eradicate. Actually, cancer screening can be done for all the women between after 20 years. After 20 years, we can do pap smear, and after 30 years, we can do HPV testing. But almost 80% of women will be having HPV positive, but they are all not prone for cancer. Only those who have a sequence of 16 and 18, they are prone. So that's why cancer screening now the new guidelines they are telling both pap smear along with HPV if they do it once in 5 months, 5 years they can have screening. If it is negative we can wait for another 5 years. If it is positive we have to see
Yes,
go for
madam.
the colposcopy, and also if there is a positive treatment will be by cryocautery or thermal ablation
Yes,
or
madam.
the
They
leap.
were
Yesterday
listening to
there was
huge.
very much
I was here only yesterday.
yes, there was a
lot of
yes.
information I gained.
So WHO has given that 90% of girls before 14 years they have to get vaccinated, or after 15 they can have 3 doses of vaccination. 70% there should be
So,
screening. And
vaccination.
Vaccination they are promoting for 90%.
Yes.
Before 15th birthday they can give 2 doses, that means a quadruple vaccine, and after 15th birthday 3 doses can be given. 70% of women has to be screened. In that if they are seen positive findings, they are 90% has to be treated by cryocautery and thermal ablation.
Yes, madam.
No need of hysterectomy if it is in early stage.
Yes, madam. Now, what is the role of PET-CT? Karthik, you are young, energetic.
As such, if you ask me, there is in early stage primary cancer, there is no role of PET.
Yes.
Only in recurrent disease only PET scan role is there.
That
And
is also again investigation.
Investigate, yes.
I tell you, the patient of carcinoma esophagus received chemo radiation, and then after 6 weeks patient took PET-CT, positive for esophagus and liver in the left lobe margin, underwent McEwan's procedure and liver resection. Both were negative for malignancy.
Sir, in this case, after radiation therapy, a minimum gap of 3 months should be there. 3 months should be given. So otherwise, if radiation takes that
So
much
you
time
wait
to
for
act,
3 months,
yeah.
then do your PET-CT. If that is negative, you can't leave it also.
So dictum is 4 weeks after surgery, 2 weeks of after chemotherapy, 12 weeks after radiation therapy. Before
Okay.
this, PET-CT will give
I
false
don't know.
positives.
So PET-CT, one simple thing, somebody quickly want to know I have cancer or not, do your PET-CT. What is being done? I don't advise like
PET
that.
is no substitute for HPE, sir.
Yes,
Liver
sir.
lesion, they
That
should
is
have done a biopsy, definitely.
Yes, sir.
Sir, with your
No,
permission.
liver was in the left lobe of the liver at the edge. So we have opened the abdomen for conduit.
Okay,
So cut that liver also.
Okay,
It
right.
was typical deposit nodule. I have not seen such a negative report. We don't do PET often. That is our thing. It is evolving under
It
investigation.
all depends on the availability.
Okay. Thank you, madam.
Sir, with your permissions, 2 points
Yes,
I would like to
madam.
make. Because the majority of them are gynecologists. Sometimes we do see a patient after having a pap smear and coming with a report that shows an inflammatory smear,
That is
and
there.
the patient will be having an obvious growth. So do not do a pap smear when there is an obvious growth. Do a biopsy only.
Biopsy?
That is one thing. Second thing, for the investigations, among the investigations, probably examination under anesthesia will give a lot of information whether the parametrum is involved or not.
Yes.
There are certain patients where the heavy, built, where a pervasive examination without anesthesia is not very good. Where under anesthesia, if we examine, probably if we are doing a biopsy under anesthesia, and we can see that also, examination under anesthesia is one of the very, very good thing to accurately stage a cancer cervix.
Yes, sir. Thank you.
Thank you, sir.
Thank you, Jaykumar sir. Thank you, panelists, for elaborate discussion and enlightening us on gynecological malignancies management and diagnosis. I would like to invite Sri Sunita madam to give memento to Jaykumar sir. I invite all panelists to join. I invite Sunita Subramaniam madam to give memento to Bharti madam. I invite Sunita madam to give memento to Surasens sir. Anis, all Sunitas in stage. I like to invite Radha madam to give memento to Nageshwara sir. Jai Radha madam. I invite K. Madhavi madam to give a memento to Karthik. Mm. Thank you all. As we are running of short of time, the session will start at 2:30 sharp in Hall B. Thank you. సర్లేండి